Today, we're going to talk, the first session, we're going to talk about inequities during the COVID-19 pandemic. And we have a wonderful panel for today. And here are our wonderful panelists. And I don't know anything about them, so I'm going to let them introduce themselves to you, okay? We have Pia from Thailand, Lisa Hirschhorn from the USA, Calvin Ho from Hong Kong, and Wei Wei Han from Myanmar. And they're going to talk about everything about inequities. However, I'd like to give a short introduction to this whole concept of inequities. Here, I have a picture demonstrating equality and equity. Those are two different terms. Equality means equal resources, and equities is more of a social justice term. And here we see everybody has equal resources. However, this person here is at a disadvantage. And to correct this inequity, he gets more resources. Now, having said that, there's something wrong with this picture. What is the root cause of this person's previous inequities?
By the system itself, there is some issues with that person. Maybe more resources are provided to a person who's having, maybe let's say, some disparities.
Well, what's the cause of his disparity?
Probably there is a systemic problem. Maybe it is congenital or a dwarf or whatever it is like. No? I mean, there is a system problem. There is a system problem, Henry. I mean, probably constitutionally there is some problem in the sense, in terms of genetic, or probably some issue is there in the system itself, the person.
Yes, it's something within the person.
Yeah.
But not with society.
Correct.
Okay? So
correct.
That is not demonstrating what is wrong in the social, environmental context. Okay? That's the problem. Race disparities, solutions lie in policy, not biology. Here's another picture. We have equality and we have equity now with more resources. But now, what's the source of the previous inequity? It's not biology. They're all at the same height.
It's basically environmental. So the difference in the height of the fence.
He's on a lower ground. The root cause is in the social, environmental context. And now, there's still something wrong with that picture. You're correcting it by giving more resources, which is okay, but you're not addressing the root cause of the inequity. You're not fixing the social, environmental context. I mean, you're giving maybe a one-time payment, which is fine, and many governments are doing that in this pandemic, but it's not everlasting. Now, a better picture is this: liberation. Another similar picture showing socially disadvantaged neighborhoods here compared to here, and now you have equal community resources, and to fix this inequity, you give more community resources, and essentially you're trying to fix long-standing systemic racist social policies. Other sources of inequities would include, racism, systemic racism, oppression, previous slavery, and other discriminatory policies. Colonialism as well. So essentially we have inequalities, inequities, and inequities refers to a social justice concept. An ethical framework for allocating scarce medications during COVID. Here are some ethical goals: prioritize saving lives, essential workers, make sure your policies do not exacerbate disparities, but you also want to mitigate health disparities. So in terms of mitigating disparities based on experience with previous pandemics, it's reasonable to assume that pandemic influenza can cause case fatality rates for some groups that are higher than the rates of other high-risk groups. For example, it may become evident during a pandemic that a certain demographic group or group with compounded social vulnerabilities may be at a higher risk of death. So with racial, ethnic disparities, the cause of that is, social distancing is a privilege among certain groups. Some groups, because of pre-existing inequities, cannot social distance, and maybe we'll talk more about that during the panel discussion. So why do we want to correct the health disparities, the inequities? Well, for the good of all of us. And let me fast forward. What is fairness? Justice as fairness? Well, essentially, Martin Luther King, injustice anywhere is a threat to justice everywhere. We are caught in an inescapable network of mutuality tied in a single garment of destiny. Whatever affects one directly affects all of us. And so what is fairness? If groups with compound social vulnerabilities are at a heightened risk of mortality and serious morbidity, then the members of that group maybe should be prioritized for access accordingly. And maybe we'll talk more about this during this session. So essentially, during a pandemic, we can have the ethical principle of enhancing medical benefit and give priority to those who are most likely to survive. We could honor reciprocal obligation to essential workers and give priority to those who's on a list of essential workers, healthcare workers, and also we could use the ethical principle of mitigating health disparities and give priority to those from disadvantaged areas. And some people recommend that we should look at what's called a deprivation index of a community, and those who live in a higher deprivation index, meaning a worse social environmental context, should get priority for scarce resources. So with that introduction, we would like to start our wonderful panel discussion. So thank you very much. What's the arrangement? Pia, do you?
Yes,
Go
Henry.
first?
Yeah.
Okay. How? Do you have slides?
Yes, can you see the
Okay.
slide? Okay. Hi, everyone. Thank you, Henry and Vina, and the organizer for the opportunity to be here. My name is Pia Han Warawongchai. I'm currently a lecturer at Chulalongkorn University, but also program director at the Equity Initiative, which is a program under CMB Foundation. I'm based in Bangkok, by the way, and I'm also working at National Health Foundation as a Secretary General. And it's a wonderful opportunity to maybe share with you a little bit my thoughts on COVID-19 and health equity with the view on Thailand and ASEAN countries, which we are working on. As you may see, basically we have been in this pandemic for quite some time. I remember from about 12 years ago when I was still working for London School of Hygiene. At that time, we had a project called Asia Flu Cap. Basically, we looked at the preparation for pandemic, trying to prevent flu and trying to mitigate the impact from flu. At that time, we tried to convince people that there was a big serious issue, a lot of many tens of millions of cases and deaths and others. And it's quite sad to see the things still happening and a lot of deaths happening and quite surreal in a sense. And to me, I'm quite lucky. We are in Thailand. We can still live pretty close to normal and can still take my kids to the playground in the neighborhood or go to the street shops, street food nearby. But I know a lot of colleagues and friends, especially outside, who really are suffering from this. Some never been out of their house since March, and some lost their relatives and family. So I think it's a major impact that we are learning from, and hopefully with some new advancement, new changes in both technology, politics, and others, we would be able to handle it better. But my main point to raise here is that the COVID impact is actually not just about the deaths or cases that we are seeing. We also see a lot of indirect or other health impacts that are not directly about the COVID disease. For example, a lot of people are suffering from mental issues, stress, anxieties, and including stigma and discrimination. We also have issue from the provider side, hospital side. In many places, there were cases that couldn't get medical care they're supposed to. And we probably have seen some statistics on excess deaths that happened during this period, both from the stress in the healthcare system, but also due to the mitigation effect of public health measures like movement control, lockdowns, and other. And I would say that the biggest impact, especially in Thailand, where we don't have that many cases, we so far have only about less than 4,000 cases total for 66 million population. So we have done pretty well, quite lucky with the COVID, but the economic impact is huge, and the subsequent social implication that come from that is also a very big one, because Thailand rely a lot on tourism as well as some other export and import. And I would like to raise awareness to one of the key issues is related service disruption. And we have seen this to a certain extent, but we will still continue to see the effects of health service disruption coming up over the next year or even longer, partly because the impact is not limited to just medical care. One study published in The Lancet earlier this year talked about, for example, immunization that is currently being impacted in many regions that may lead to long-term impacts in terms of potential child mortality increase as well as potential child development problems. We also see that we also see that this kind of challenges happen in Thailand due to the partial lockdown that we had. The number of outpatient visits declined significantly in April and May, And even though we kind of resume the service and lift the lockdown, the recovery in terms of outpatient visits still lacking behind in terms of the about 10 to 15% lower than the usual. And in terms of the effect from the economic situation, it is quite clear that this is going to be much broader than medical or health, as we expect that poverty will increase, access to care, but also access to necessity like food, nutrition, and others will be declining. And at the same time, in terms of the service system, we may face with lower utilization, lower budget coming to health sector due to lower government revenue, and potentially other expenses and other impacts that come from COVID and related system response that may jeopardize how we cope with medical care, how we cope with health promoting activities. This is a framework raised by Professor Butta, Sufika Butta, in 2008 after the economic crisis in Asia at that time, and they look at the impact on food and nutrition and long-term effect. And they argue that there are many pathways that this kind of economic crisis can lead to longer-term cognitive impairment, development, slowdown among children particularly, and even the reversal of previous gains that we have had. And we already saw some statistics from World Bank and others about the potential increase in number of people falling below poverty line and other effects. So in our analysis in Thailand for the government, we look at this COVID-19 impacts as triple threat, both from immediate COVID threats, from public health and health system measures that lead to adjustment in both demand and supply side, and also the result from economic crisis. Even though there are also some good news, for example, in Thailand, the number or the incidence of respiratory illness declined significantly because of changing behavior, number of traffic accident change. But we expect to see a big increase, for example, in terms of mental cases, mental illness cases. Suicide is expected to increase. We expect 3,000 more suicide dates this year. And we are still trying to look at the medium term and long term impact and try to carefully look into and monitor this impact. And all of this were just overall impact, but in this session, we talk a lot about equity. And as you know, usually this impact fall much harder among the people who are poor, among the people who are vulnerable. And thanks for your answers to the question. I had a quick look initially, and there's a lot of stories about issues that you have raised. For our program, the Equity Initiative, we also ask our fellows who are spread out in Southeast Asia to also try to document the claims of this COVID-19 impact. And one group that showed out, and this is an example, for example, from Singapore, who managed to control COVID very well at the beginning, but at one point, the disease, the infection erupted and spread very quickly among migrants who being shown to be living in a very bad or not adequate satisfactory situation. They don't have good food or nutrition, and they don't have good access to primary care in order to help them get early tests or early treatment. And the situation was not just in Singapore, but also in many other countries. In Thailand, the migrants, especially overseas migrants, are the first to be get out of the jobs, and they probably have to suffer because they don't have social protection, they don't have social insurance and others. Even more severe is among people who have disabilities or existing chronic illnesses and others. The story from our fellow Lertiniat from Vietnam talk about how these amputees have very difficult condition, not be able to earn their living because of the lockdown. At the same time, the services provide, healthcare service and other are not available to them. And it's more difficult and more struggling for them to address. So the COVID both disproportionately affect the poor, but also the collateral effect of this pandemic from the economic downturn and social isolation also even make things much harder. And on this, it reminds me of this framework on social basis of disparity by Direction and colleagues, who talk about the importance of social position in shaping both the exposure. COVID is a good example. A lot of people, Henry mentioned that self-quarantine is a privilege. Many people couldn't do that because they need to earn their money even very little. They cannot stop working for even a day, and they have more chance of exposure to the disease. At the same time, vulnerable population are more susceptible to the disease and more vulnerable when they get the disease to get sick. They could get more severe because of their poorer nutrition or other circumstance. And usually when they get sick, they get more severe consequences, both from the health consequences, but also social consequences. For example, if they don't have, very likely they don't have medical insurance, they may have to borrow a lot of money from people that they have to pay very high interest. And sometimes they have to forego the care and then suffer, and you lost the income earning member of the family. So all of this create a cycle, a vicious cycle of what we call the social implication of health. And there are many entry points, if we talk about that, we can try to change, not just in terms of providing medical care, but also changing the vulnerability exposure as well as the social position of these groups. And one important thing just to raise is World Bank IMF just released its working paper about Asia last month, saying that income inequality in the region was already high, and it has been rising even before COVID. And they expect that income inequality will rise even further over the midterm after COVID, unless we have policies to try to break this pattern. And I believe health policy as well as health research can be one of an important instrument to try to address this. And I will not go into details about this, but just raise one framework that I like a lot from Kilburn and colleagues, that health research can be important in addressing or helpful in addressing health disparities in at least three ways. We should at least pay attention, put on equity lens to look at the issues in detecting or identifying problem, and trying to show the discrepancy or the injustice that happen. And I think many of our research has been focusing on this already in terms of trying to identify, detect, compare. Even though in Asia we don't see that enough, partly because of the data and others, we need to pay more conscious in looking at this and trying to look into subgroups. Average is not enough. But even beyond that, we should also pay attention to understanding and reducing, which I believe today I will also be very lucky to have a chance to learn from all other panelists who are coming, Professor Lisa Hirschhorn and Professor Calvin Ho, who will be talking more on that about research to help us understand and to reduce health equity. And one almost last point is that most existing strategy to reduce disparity is to target patient and provider in the medical care system. And this is from Shinman and colleagues. And please don't forget the system level factors that Professor Henry Silverman mentioned just not before this. And we should try our best to also address those beyond just the usual patient and provider kind of solution. So I think that's all for me just for now. Thank you.
All right, that was excellent. Should we take a few questions? Vina, what do you think?
I think it will be good to have all the panelists speak because there's no specific questions so far yet, and we can speak. We can address the same questions to all the panelists.
Okay, sounds good. Who's up next? Lisa?
I think I am, yes. So
Okay.
Good day, good evening, good morning, depending on where you are.
We're like-minded, Lisa.
Just cover all the bases. I am absolutely delighted to be talking. My name is Lisa Hirschhorn. I'm professor of medical social sciences at Northwestern University Feinberg School of Medicine. Originally, I'm an HIV physician back in the 1980s and 90s, and spend a lot of my time thinking about why people don't get the care that we know works, and have therefore spent most of my life in looking at issues around quality disparities and implementation research. And so I'm going to just spend a little bit of time talking about sort of some of the promises, but also the challenges of using implementation research during COVID-19. But before I start, implementation research being relatively new, we always say if you ask 8 implementation researchers, they'll give you 9 different definitions. So I'm going to try to do something relatively simple so that we can all be on the same group as we talk about this. So implementation practice is what we do. It's the use of strategies to adopt and integrate evidence-based health interventions and change practice patterns within and across specific systems. So it's sort of things around local knowledge, for example. How do you actually get people to wear masks? How do we, what kind of other initiatives are happening? Now, implementation research then looks at the use of these strategies. Are you doing training or stakeholder engagement or structure, changing systems to integrate these into real world settings to improve patient outcomes? So you're trying to not just make improvement, but also create generalizable knowledge. And that's where I live most of my life. Implementation science is the study of the methods that we would then use to do this, to promote the integration of research findings and evidence into healthcare policy and practice. And then quality improvement, which is again where I spend some of my life, includes many of these strategies. So there is some overlap to help the integration and delivery of these interventions, but is often focused on local change. And so really is not as much thinking about how do we actually accelerate change and spread knowledge through implementation research. Now, there's another way of thinking about this simply, which is the intervention or practice or innovation is the thing. Mask wearing, social distancing, you name it. Effectiveness research is important. It looks at if the thing works. So, for example, let's take the vaccine. So the effectiveness research is it actually working? Now, implementation research is how do we best help people or places do the thing? What are the strategies to make people wear masks? What are the strategies we're going to need to have people accept vaccines and make sure it gets to them? Implementation strategies are the stuff we do to help to try people and places do the thing. So, for example, again, community outreach, getting champions, doing audit and feedback. Now, one of the differences that in addition to effectiveness, implementation outcomes look at how much and how well people actually do the thing. So, for example, who's wearing masks and who's not wearing masks? Who's able to actually social isolate and who's not able to do that? And critically, and this has already been brought up in some of the differences that we've heard about, and for example, I'm not actually in Chicago, but in Chicago, where there's an estimate about 1 out of 15 or 18 people are actively infected with COVID, quite different than clearly what's happening in Thailand. What are those factors that either help or hinder the implementation strategies and outcomes to get people or places to do the thing that we want them to do, either directly or indirectly? So how can implementation research help as we're looking to address inequity? And you'll see that some of this is overlaps with some of the really excellent discussions that was already presented, for example, the Kilburn framework. But again, it provides frameworks to help us understand the causes of gaps in the care and the outcomes. And this goes beyond just, sort of the things that we know about, but really thinking about this contextual factors. And as already been taught, it's not the individual behavior. Often it is things in the external environment. It's the systems, it's the cultures, it's the social determinants of disease that will really impact the access, the uptake, and the quality. And also the variability of implementation. So why is it that, for example, mortality rates differ variably in hospitals? Some of it indeed could be due to underlying conditions such as diabetes, but often it has to do with issues around quality. Finally, the other thing that it helps us do is to move beyond the understanding, beyond the understanding of why the problem is, but to really help us understand why some things are working and transform that into actionable knowledge. So it goes from really this understanding to movement, and very importantly, sort of help adapt and scale interventions that have been proven successful in addressing inequities in other settings. So for example, we've actually been spending a lot of time figuring out, what did we learn from Ebola? Why is it that some communities were hit very hard and others were not? And what were some of the strategies, like, for example, using community health workers, that actually reduced the impact? Now, this is really important when we talk about these implementation outcomes. And the ones that we really focus on are can the program be adopted? Are providers, are public health individuals, are they willing to actually take this on? When they do they deliver it with fidelity? So they deliver it the way they're supposed to. Are they reaching the intended population? And then very importantly, if this happens, will organizations, whether they're public health, whether they're hospitals, whether they're other types of organizations, will they sustain it? And the reason this is important is if you have something that happens to be 100% effective, but only 50% of people are actually providing this, it's only delivered with about 50% of quality. It's only reaching 50% of your intended population, and only 50% of the organizations will be able to sustain it. So this 50% threshold, only 6% of the population will benefit. So you've started with 100%, and simply by poor implementation, you actually end up with a very poor population benefit. And this often can make you say, well, the intervention doesn't work. And the intervention could work, it's how we implemented it. And that's what's a very important thing to keep in mind. Now, what can happen when we look for improvement? So again, this is very similar. This is probably a much more boring representation than the people behind the sports fence. But basically, equality is everybody improves, but the inequity remains. So you're seeing that people got better, whether they were in the highest, for example, wealth quintile, lowest, but there's no change. Something that often happens is what I call the low-hanging fruit, which is that the more advantaged people or places get better, but inequity worsens. So often, for example, if you have some of these interventions, so for example, testing, what you can see is that people who have more money, who are more advantaged, are more likely to take it up, and people who are more poor, who are not able to get off work, are not. So you've actually worsened inequity by putting in place an intervention. Now, if you put in place what's been already called an equity lens, so you're focusing explicitly on the most disadvantaged, then what you see is that everybody improves, but the improvement is more in the disadvantage, and the inequity gap is reduced. And that is really the goal of what we want to try to figure out how we should do this, and is it indeed happening? So for example, if we look at this idea about inequity, so let's say for the most advantaged, there's actually an 80% threshold. So 80% of the providers are actually giving the right drug or providing the right advice. 80% of the time it's being done with quality, 80% of the population is being reached, and 80% of the organizations will sustain it over time. Whereas in the lower, more disadvantaged groups, more vulnerable groups, you have that 50% threshold. The 80% threshold, 40% of the population will benefit versus only 6%. So obviously still we need to do better, but you can see how this drop-off really is very, very harmful to the most vulnerable. So there's a very nice paper that was actually written by colleagues of mine, which is sort of thinking about implementation research, and that there's sort of three methodologic paradigms that we might bring to bear as we think about how do we actually understand and better address these inequities. Now, there's a couple of things that we can do. So the first is that we can use existing data to model or better understand the impact of implementation. So again, go back to that idea of the 50% or 80% threshold, that we're actually be able to understand what happens if you're not reaching people, what happens if the fidelity or the quality is actually more poor. And you have to be able to disaggregate or model. So this will give you a first step to say, is this actually happening? Now, the second is to make sure that you are explicitly including populations with health inequities in new implementation research. So you want to make sure that you're including these populations and that you're including them with enough numbers that you can actually understand, are you making a difference? Are you worsening inequity, or are you actually making it better? And then finally, you can actually choose to do implementation research that's focused exclusively on the populations experiencing inequities. So with a certain population, for example, expanding the reach of existing evidence-based interventions who have populations with scientific or health inequities. Now, for those of you who may be writing grants, you will potentially get criticized for this because they say, oh, there's no control, there's no counterfactual, but this is actually a very, very effective way of really doing the kind of work that's needed to do to understand and address the challenges of people who have the most inequities. So then the other question is, what can you do about the contextual factors underlying inequity? And this has already been brought up, the fact that it's not race, it's actually racism, that it's not really biology, it's actually the barriers that people have. So the first thing you can do is you can address them directly. Medicine is rife with what we call implicit bias, as well as explicit bias, disrespectful care, workflow problems, social determinants. Each of these could actually have strategies that are explicitly done to actually do this. If you have implicit bias, what kind of training and feedback can you do? If you're having disrespectful care, how can you measure it and provide the incentives to actually have people provide respectful care? If it's social determinants, how do we expand the strategies we have to go beyond the health system to actually address issues, whether related to poverty or to nutrition or other areas that are not typically felt within the health system? Second is you can adapt your strategies to leverage if a facilitator to change, if it's a facilitator to actually do that, or address it if it's a barrier. So for example, if there are indeed financial barriers, how can you actually figure out how to actually reduce those? Can you actually get rid of, for example, user fees? There's a very famous study that was done to actually improve diabetes care, and it got worse in the Spanish speaking community because nobody actually bothered to adapt and to do a cultural translation of the materials. And how can you actually do your strategies to actually accept and work with the cultural norms? And then finally, sometimes you have to acknowledge that these are longer term or broader engagement. For example, inequitable distribution of facilities. Hard to quickly build those facilities, but it is something that we have to think about in terms of our advocacy and bringing out the evidence so that policymakers and funders are willing to actually invest in those longer term solutions. So how can implementation research help with the COVID-19 response? So we know that there's these evidence-based interventions, right? Mask wearing, social distancing, hand washing, but they're not being implemented well, and the contextual and the implementation outcome barriers are pretty clear: feasibility, acceptability, adoption. So there's been a number of papers that are starting to come up about how we can actually use this as a very important tool to understand why people are not doing what we know works. Now, one of the work that I did with some colleagues at Northwestern is focusing within the United States. Clearly, we are struggling with getting people to do what we know works. We see people still not wearing masks, despite the fact, as I said, in Chicago, about 1 out of every 15 people is actively infected. The estimation for the US is about 1 in 100 right now. And in addition, not only is it bad, but we've already seen, it's been discussed, that the pandemic in the US has had a much greater impact in more vulnerable and underserved populations. And we see this, the mortality rates initially reviewed through a racial lens, but it's really that they are higher in people with lower socioeconomic status or other surrogate markers of structural barriers such as racism. And there's really a number of contextual factors that we understand why we see this, as well as if we look at the outcomes of things like feasibility of people. For example, as was already pointed out, that social distancing is actually a luxury. So again, it's more due to these barriers or access and uptake than biology. And this is a really important thing. I come from HIV. Initially, women were dying much more frequently than men. And everybody said, oh, HIV is different in women. And it wasn't. It's really the barriers. We're seeing the same thing again. Biology plays a role. People who are obese, people who have diabetes, particularly untreated, are more likely to die. However, there's a lot of underlying reasons why that is seen more frequently in some populations, particularly those that have not had access to quality care. Now, there's also the barriers to evidence-based interventions such as testing or masking, for example, clients in retail stores and other actors such as household crowding. And each one of them requires us to understand and listen to the community to figure out how we can actually develop strategies to overcome them. So how can it help? It can help by helping us understand these contextual factors in the external environment, whether they're at the system level, at the government level, at the community level, but also at the individuals and families, as well as the health systems and the interventions that are currently resulting in disparities. And the disparities really are on access, on uptake, and on these implementation outcomes. For example, is low testing due to access? So is it a problem of cost? Is it a problem of geography? Is it a problem of where you work? Or is it an acceptability issue? For example, fear of diagnosis. If I get diagnosed, I will lose my job. If we want to actually do a strategy to understand and to address inequities in testing rates, we need to understand that. And so, for example, when that's understood, evidence-driven interventions or strategies have included expanding of test sites into community settings, contact tracing using community-based workers to overcome suspicion and to address issues around access. Another one is, for example, is social distancing acceptable and feasible? Well, if you're in a multi-generational or more crowded housing, it makes home isolation not feasible. And so therefore you need to access other good options, such as, for example, some of the quarantine places and other strategies. So it may be not just unacceptable, but also not feasible, because you need to have not just these alternate sites for isolations, but structural support, such as, for example, food packages for people that actually need to be able to go out each day and get food and get nutritions. So what are some of the core strategies which I think are going to be important to help us address the inequities? Stakeholder engagement, and particularly community participation, is probably one of the most important strategies. Human-centered design, understanding what people's barriers are, whether they are physical, whether they're motivation, whether they're knowledge. Making sure that when we measure effectiveness, we're also measuring these implementation outcomes of acceptability, appropriateness, adoption, et cetera. Community information, education, and communication that's sensitive to linguistic and literacy. Adaptation to reflect the local context. And very important, we need to make sure that we know if what we're doing is making a difference through data audit and feedback. Now, implementation research we know can help accelerate when used well. And these are just some of the frameworks that we use. So for example, this is RE-AIM, a very common framework that we use to measure implementation outcomes. CFR, the Consolidated Framework for Implementation Research, that really helps you sort of distinguish what kinds of contextual factors you'd be asking about. This is probably the most commonly seen logic model for implementation research. And then very importantly, that when you, if you want to disseminate, we want to spread, we have to be very careful about understanding what it is people are doing. And there's some very good frameworks to help you figure out how you actually define a strategy and then be able to actually share that with other countries or other settings within a country. So I think, in general, implementation research, like I said, is really something that's emerged over the last 5 or 10 years. It's a little bit longer. It's really based on this idea about how do we get people and how do we get systems to deliver and to use the things that we know work. But to do that, we need to expand what we traditionally measure. We need to make sure that we're constantly measuring for inequities and disparities rather than assuming that we are actually making a difference. And I think it's a very, very powerful tool to help us accelerate the work that's needed to bring the pandemic to an end. Thank you.
Thank you, Lisa. That was excellent. Very good. Okay. So next we have Calvin.
Hello. Okay, can you hear me? Am I coming across? Okay, right.
Yes.
Okay, thank you. So let me get started. I'll share my screen.
Well, hold on for a second. Someone's having a conversation.
Okay, right. Thank you.
So I'm going to mute everybody. And then you have to unmute yourself. Okay.
Okay, so can you hear me?
Yes, right. Okay.
Okay, that's brilliant. Yeah.
That's
So I'll get started. Thanks very much.
okay.
Yeah, so first of all, a big thank you to Professor Silverman for this very kind invitation and the opportunity to discuss an important issue with colleagues as well as to learn from everyone. So I thought I'll pick up on some of the points that's already been highlighted by our colleagues earlier, but also to bring in the ethical dimension of things. So I'm particularly interested in digitalization, and of course we've got digitalization happening quite aggressively across the Asia Pacific region. So I thought I'd speak to some of these developments, but very much we focus on the very important place that we see in having equity featured in our research. So in terms of the key messages, so I'll just highlight in terms of broad context, digitalization that's happening not just in relation to public health interventions, but a range of health services. And we argue in one of our papers that at least in the in the East Asian region, it's very much facilitated by the current pandemic. So of course, what's very clear would be the use of contact tracing apps. I think it's important that as we think about digitalization across various domains, we still need to keep focused on equity and justice. We've seen that these are rather complex terms, but what's very helpful may be to look at some of the international documents and international ethical documents and its focus on vulnerability. So how could we make use of the construct of vulnerability to think actively about addressing equity concerns and hopefully facilitating progression towards a fairer or more just society? So there are a number of research considerations that we might want to take into account. I think a number of which have already been highlighted by our colleagues earlier on, and the one of the objectives of my presentation would be highlight the ethical basis of it and to see how we could push even further as we move towards meeting the SDGs. So in terms of broad context, I've mentioned earlier, we see lots of digitalization of various interventions happening across East Asia and also around the world. So we focused on the East Asian region and also inclusive of Australia and New Zealand. So we'd have the use of contact tracing apps. Of course, this would be very important in thinking about, as a broad context, the sort of implementation research that we've heard Professor Hirschhorn mentioned earlier. So how are these particular devices being used? Are they in fact being used, and to what end? So are these devices actually helping to lower or flatten the transmission curve? So how do we think about the resistance among some quarters in taking on such technologies, and what are the implications of them? And more importantly, in thinking about digitalization, how do we understand, how can we go about understanding the digital divide that is emerging in many different ways? So the use of digital tools for research purposes, of course, it's quite a new endeavor. So even within a research ethics sort of context, we're still, in a sense, feeling the ground in identifying the sort of key concerns that we ought to take on. So here in this very helpful paper, there's been a discussion of some of the things that that an IRB or REC, depending on which part of the world that you are, if you are submitting a research protocol, some of the considerations that should be featured in a research protocol and clear procedures or clearer procedures are being developed around the world. But if we think about more broadly how the research ethics or research governance framework interface with other sorts of frameworks, there is a clear ambiguity, particularly if we think about the more public health related sort of activities. So where they are considered to be research, as we know, there would be, by and large, in many places, a relatively clear research governance framework. So as I've mentioned earlier, this would involve an institutional review board, an ethics review committee or research ethics committee, depending on where you are. So within a research sort of context, there would be a sort of oversight mechanism that's in place. But of course, one of the challenge, even within a research sort of setting, is that we may not find equity as prominent a concern in some of the research protocols. Of course, some of which may be warranted. Others, I think researchers could in fact do better in thinking about how to improve the equity features of what's being done. But when we move beyond research into some of the other domains, particularly where it pertains to public health, firstly, the governance mechanism may not be all that clear. So one may not have expected, for instance, a lot of the public health interventions to have stretched on for such a long time, or at least in this part of the world, that hasn't really been the case with SARS. So I guess one feature would be, in terms of COVID-19 as opposed to SARS, the experience with lockdown and with a number of public health interventions has been rather more protracted than expected. But what's important would be to think about, in terms of the comparative lack of governance in terms of activities that falls beyond what is the classical research domain, it will be a good opportunity to think again about the sort of issues that were considered in relation to, say, for example, differences between equality and equity. I thought this slide is important for, at least from an ethical standpoint, and other reasons, because when we think about justice, there are many different ways of thinking about this, of course, depending on your philosophical tradition, depending on your the communities that you're working with. As we know, when we think about justice, there might be perhaps more welfarist sort of understanding of it. There may be more egalitarian notions that may be implicit in this chart or in this graph. There may also be more communitarian approaches. So well, in a sense, because there are all of these various interpretations of justice, we need to actively engage with it. Of course, this would be essentially high-minded principles. But if we look at how equity or justice is being taken up in international documents, and there's been quite a few issued by WHO and related entities, encouraging us essentially to think harder about how we could try to steer our work towards meeting these sort of ethical goals. And when we think about equity, there has been a particular interest in advancing understanding on vulnerability. So when we think about attempting to address social injustices, how can thinking about vulnerability help us to design our intervention and study our intervention in a way that could help reduce inequities? So vulnerability in research ethics, of course, is not a new concept. It's been recently taken up in a strong way in the revised guidance from CIOMS. So here, a clear feature on what might be classically known as vulnerable populations, but also challenging at the same time, or challenging us at the same time to think beyond these sort of classical categories and to take a more fluid approach in assessing what might be vulnerable in particular groups or individuals involved in the study. So this would be, of course, clearly set out in the explanation to the CIOMS guidelines. So you're welcome to have a look at this document, very instructive. And as I've mentioned, essentially for CIOMS, it's essentially directed at a relatively well-defined research community and involving a relatively well-defined scope of work relating to essentially health research. But moving beyond what might be classical research ethics kind of domain, as we move closer towards other sorts of interventions that might be of a more public health nature and perhaps more pertinent to implementation research that we've heard earlier on, there has also been a number of guidelines in this particular guideline by WHO, and specifically in the context of an outbreak. How should we be thinking about vulnerability in that sort of context? And here, as you'd see, there's been a number of experiences that's been, in a sense, considered and captured within these sort of guidelines, particularly from more recent outbreaks in Ebola specifically. So what might be helpful, at least for researchers, in terms of thinking about the research design and more generally in terms of the interventions that we want to put in place, including those that are intended to address a number of concerns arising from the COVID-19 pandemic, are these questions. So it will be helpful to consider why certain individuals are considered particularly vulnerable. And if we think about it, how are they affected? Is it because of access to services? How about the information that's been received? In fact, if we think about digital technologies, what might be interesting to consider is that while these technologies could help individuals access assistance, medical assistance, for example, in a situation of lockdown, or otherwise be able to help them navigate around the public health situation. Why are these technologies not taken up? What exactly are the barriers? What are the hesitations? Is privacy the main concern? Is it the only concern, or are there other concerns? And how do they ultimately relate to the sort of technologies that we're thinking of? So these are some questions that I think would be quite pertinent when we think about whether it's implementing a particular intervention or otherwise studying the sort of intervention. And of course, in the guidance as well, a number of considerations are also highlighted, that particularly in terms of concerns with stigma and discrimination. So, of course, this may be not as well considered in relation to some of the communities, but we see that being exacerbated, particularly where we consider the application of digital technologies in a number of contexts or in relation to a number of communities. So similar kind of considerations have been taken up in the WHO's guidance on ethical issues in public health surveillance. So here, moving quite clearly away from the domain of what is strictly a research kind of context and more broadly in public health activities, a similar emphasis on thinking about how do we reduce harm or avoid harm altogether. Of course, this would mean having a clear sense of what exactly harms might be. And oftentimes we might find that given the exigency of the matter, we want to move ahead with interventions very quickly, essentially to stem the transmission rate. But in fact, it might be important to just take a step back and to consider what exactly are the harms that might arise as a consequence of introducing such an intervention. So, of course, in terms of thinking about harms, there are various forms, and these are some examples of them. So, have we considered, for example, in a very concrete way, the sort of economic impact that would have if we were to introduce social distancing and for a particular duration? So what are some of the means that could be taken up in addressing some of these concerns? And we have already considered earlier on the psychological or emotional impact that some of these interventions could well create. So apart from just giving visibility to a number of these challenges, it is also an encouragement for public health workers and more generally, so people involved in a number of activities directed at addressing the COVID-19 concern to think actively about harms and ways to reduce them. But it doesn't quite stop there. In fact, the guidance encourages us to think more broadly, take a longer term view essentially in thinking about how these interventions could have an impact beyond what would be more immediate concerns, and how these could be thought of in terms of benefits and harms. And also to think about particular susceptibility. So there we could consider what might be immediately vulnerable individuals, but then taking a broader view, what might be whom, or rather I should say, might be the individuals who could be susceptible or become more susceptible to harm as a consequence of particular actions being taken. So here again, I think there are a number of important questions taken up in a somewhat different document, and some of you may be familiar with this document. It's been issued last year jointly by the World Health Organization and the Alliance for Health Policy and Systems Research. So I think a number of important questions raised to try to bring in the justice dimension. So I think it may be helpful to just quickly go over these points, essentially thinking about whether the research project, if it is to be research, address a local health priority, are there particular hidden groups, and or for that matter, are there any groups that's been unfairly excluded? So notice here that we are moving beyond individuals who may be immediately vulnerable to individuals who may be made potentially susceptible to harm as a result. So are there adequate protections in place? I mean, these are some of the things that ought to be considered as well. And of course, the procedures put in place to protect the interests of these particular groups. So there, I think we've alluded to this particular goal in a sense in the earlier presentation. So while we have equality in the very first picture of, well, starting from the left-hand side, and then a more equitable arrangement in the middle. So what we're really hoping to work towards would be the right hand, the picture on the right hand side, essentially to say that we want to enable individuals to be fully engaged in the process. But of course, ideally, if we were to take on perhaps a more capability-oriented kind of approach to understanding justice, it may even mean capacitating individuals to be involved. So you see that these three individuals are behind the fence. Why are they not in the audience? And for that matter, if we look at the young child there, could this particular individual or the two young childs there, could they become essentially accomplished sports individuals whom they are now observing? So these are some very important questions that I think would be helpful to take on. So I think on that line, again, quite consistent with what has been mentioned earlier, a number of emphasis, and I think these are very strongly endorsed as a matter of ethical mandate. So emphasis on participation, emphasis on better understanding perceptions and views. And I think these are some matters that we should be taking on in a more active manner moving forward. So in conclusion, I think some of the points that have been mentioned by the earlier presenters are in a sense emphasized in these particular ethical provisions. So they relate essentially to thinking actively about not just the immediate concerns, but how in drawing on the other domains, we could better address susceptibility to harm, particular vulnerabilities as we move towards the SDGs. A longer term perspective in thinking about ultimately strengthening public health systems from the present experiences with COVID-19, and a very strong emphasis on building trust and trustworthiness in the ethical guidelines, as well as very practically continuing endeavors to engage with communities and to improve means of communication, whether we're talking about digital technologies or otherwise more conventional means of addressing public health concerns. So with this, just some very quick advertisement, if I may. We do have some activities for our center coming on, so if you're interested, please do have a look. This is an advert for it. We also have some programs which may be of interest, and if you should be interested to find out more about our center at the University of Hong Kong, so here is a website that will have more information. So with this, thank you so very much for your attention, and that's over to Professor Silverman again. Thanks so much.
Okay, thank you, Calvin. That was fantastic. Great.
Thanks very much.
A lot of food for thought. So we have one last presentation. Wei Wei Han is going to say a few words about a research project that she is going to undertake in Myanmar to address these issues that we have been talking about. All right, Wei, you're on the clock.
Thank you so much, and good day, everyone. Thank you so much, Professor Silverman and Vina, for arranging this wonderful event, and especially thank you so much, Professor Silverman, for inviting me to involve in this workshop. So I'm going to present very shortly about a research that we are going to do in a few months, exploring inequity due to COVID-19 in Myanmar. So let me start screen share. Okay. So I'm Wei Han, and I'm a research scientist from Department of Medical Research, which is under Ministry of Health and Sport in Myanmar. And at the same time, I'm a PhD candidate at Center for International Health from University of Munich. So, so this is a study. I mean, this would be one of the first initiatives to explore inequity due to COVID-19 or COVID-19 responses in Myanmar. And basically, we were looking for community engagement to ensure equitable distribution or equitable implementation of COVID-19 responses in Myanmar. So these are our research team members. So in our group, we have a researcher from University of Public Health Myanmar, myself, and Bibi Love from Australia, and Professor Silverman. So like Dr. Pierre mentioned in his presentation, that there are a lot of impact created by COVID-19 pandemic, and then the most impactful effect will be economic shock due to COVID-19 response, and then due to lockdown measures. So this pandemic aggravate the pre-existing inequality and the pre-existing vulnerability, and Myanmar has no exception. And let me explain a bit about the background situation in Myanmar. So we have found the first case of COVID confirmed case in mid of March. And we have a first wave of infection spread during March, April, and May. But at the time, we only have around 400 confirmed cases and only have 6 deaths. But at the end of July, we have a second wave or infection spread, and this time the condition worsened. And then now Myanmar is in the 3rd place in ASEAN country, after Indonesia and Philippines having a large number of confirmed cases with the case fatality rate of 2.3. And being the economic hub and then transportation hub, Yangon is badly affected by the disease pandemic. So not only due to the disease itself, but also due to the strict social distancing measures, and then partial lockdown measures and travel restrictions cause even more profound effect on the economic and social life of people living in Yangon. So Yangon, it also it's a hub of a large number of internal migrant people who migrated from different parts of the country, and then their socioeconomic status is quite low. So currently, the most vulnerable people in this epicenter of disease pandemic in Myanmar is urban slums and urban poor people. Actually, the government of Myanmar, together with philanthropies, and then together with international UN agencies and international organizations, we put a lot of effort to mitigate this pandemic. And then the government have released economic relief plan. And then it tried as much as it can to reduce the economic impact of COVID-19. However, we still have a lot of challenges to address the equity issue and then to include the disadvantaged people in the relief plan. So based on our previous research experience and based on our work experience, we found that this kind of disadvantage or inequity happens due to some limitation in trust between the government and the population, and then also that government could not reach out those vulnerable people. And then we found that community-based organizations, civil society organization, and then local leaders, local elders, they are far better than the government itself in reaching out those vulnerable people. So therefore, our research aims to develop community-based planning and implementation strategies to enhance communication of these mitigation strategies, and also to improve equity in access to government provision of COVID-19 services, not only the disease control measures, but also for the economic rehabilitations. So as an objective, firstly, we are going to approach the key informants from key stakeholders, such as community-based organizations, civil society organizations, local leaders, and academic people and local NGOs, international NGOs who are also working on this issue, so that we can optimize the current interventions, and also we can learn and we can discover new approaches that we can improve the situations. And then again, we will also approach the members of vulnerable people so that we can uncover their needs, and then the impact of COVID-19 on them, and the consequences of government policies on them. So these are the two objectives that we are going to do in this study. So this is the initial study that we want to explore the situation of who are the vulnerable, who are the most vulnerable, and then how we can help them to, or how we can help them communicate with the key stakeholders, and then we can also help them key stakeholders to reach out to them. So we will use a qualitative approach, and then we are going to do in-depth interview with key informants. So the participant that will be included in our study will be the representative from CBOs, CSOs, and policymakers, especially from Ministry of Health and School Central COVID-19 Committee, and then regional health departments, and then local investigators, and then international NGOs who are working on this issue. And then we will also interview with healthcare providers who are working in COVID-19 specific hospitals. And then we will also interview with individuals representative of vulnerable groups. So these will be internal migrants, and then urban slums in the Yangon region. So we are going to use two platforms to reach out to them. So firstly, for the policymakers, CBOs, CSOs, and then NGOs, academia, healthcare providers, we will use Zoom platform to make these interviews. And then for the vulnerable people, we will call them through mobile phone. And then we will get consent, only get verbal consent from them, and then we will do interview. So after that, all the transcripts, after when we are getting all the transcripts, we will do thematic analysis using grounded theory to describe and explore detail about those vulnerabilities, and then to find out how the key stakeholders can help to improve the situations and to involve in the COVID-19 response measures during and also aftermath of COVID-19 pandemic. So this is the end of my presentation, and thank you so much for your kind attention.
Okay, thank you, Ray Ray. Very good. Wish us all luck with this project. Very good, excellent. So that was all excellent presentations. I'm gonna need about a week to digest everything I heard. But having said that, Vina, would you like to move us along for the next 30 so minutes?
Okay, thanks, Henry. I will start with some questions from the chat.
Wait, we lost your voice.
Is that better?
Yes.
Okay. I'll start with some of the questions from the chat, and then move on to some of the questions and feedback, and then we can open out to the forum. Calvin, I see, has already started answering some, but hopefully he can also answer some on the panel. So I'll start with a question from Dr. Johnson. Why is research and medical ethics always associated with law? As in fact, sometimes investigators can get scared when we talk about legal implications, and this can lead to underreporting, especially when thinking about equity in research. It's not to anyone specific on the panel, anyone can answer. Calvin, do you want to read out your answer? Or would you like me to? Oh, Pia, do you want to answer? Just unmute yourselves, I think.
I know, I was seeing, Lisa was trying to answer.
I was going to say, Calvin, if you want to answer first from the perspective of the legal, and then I can do it from the perspective of somebody who has to then sort of deal with the consequences.
Thanks very much, Vina. Sorry, I had trouble you to repeat the question. I was a bit distracted by another question that came in the chat box. It was quite interesting on utilitarianism. So actually, rather than just responding to the question via the chat box, I'll just mention it verbally since my attention has been directed there. So I of course, utilitarianism has its place, but we must recognize that there are some serious limitations with utilitarianism, particularly if in taking a more utilitarian sort of approach, it would exacerbate the inequities that we already find in society. So clearly, for those who are familiar with philosophy, the Rawlsian approach in terms of thinking about resource redistribution is one response to some of the limitations of a more utilitarian sort of approach. There is no perfect ethical theory as far as I'm aware of, particularly if we are to implement them in either public health or healthcare sort of setting. So we need to be mindful about some of these issues that would arise. And of course, that also means that, therefore, constant ethical evaluation is important. And when we talk about ethical evaluation, it means that we must also be well informed, and ideally research should provide this sort of information in a way that could support ethical deliberation and, of course, the policy work moving forward. So that's a quick response to Ki Moon's point. Sorry if I got your name wrong, but that's what I see in the chat box. Thanks very much. So sorry, Vina. So back to your initial question. May I just trouble you to repeat that? So sorry.
That's okay. Actually, while we're on this question, in the time of crisis, should the utilitarianism be considered ethical? I just wondered if Lisa or Pia have any response to it while we're on that, and then we'll go back to the original question.
Oh, thank you. That's brilliant.
I'm going to take a pass on it because it's sort of, I think it's a really interesting question, but probably one that I'd need to go back and to some of my philosophy books to actually come up with a better response.
Pia, any thoughts on this utilitarianism question?
Well, I would say that I teach a little bit on equity also, and I usually quote Sen in 1973. He said that utilitarianism is simply concerned with the sum of utility, but totally supremely unconcerned. He used that word with the distribution of the sum. And if we are serious about equity, about these parities, I would say utilitarian alone as a sole criteria to look at how we distribute resource or how we address issue would be totally inadequate. And we need more serious consideration into these disparities, these issues that we have discussion today all the day. The challenge usually is, I think in economics there's a term, Pareto efficiency, right? If you improve someone without making some others worse off, then it's sometimes okay. But in reality, usually if we look into a broader system effects of things, it's not actually that simple like that. And sometimes we need to be very careful about that. But I'm open to look forward to listen to others as well. Yeah.
Thank you. Yeah, we can go back to our original question. I'll repeat it. From Dr. Johnson, why is research and medical ethics always associated with law? Investigators.
Can I take it? Yeah.
Sorry.
I'd like to say something about it quickly.
This question?
Yeah.
Okay. Can I just finish it? As investigators get scared when we talk about legal implications, and this can sometimes lead to underreporting when thinking about equity in research. Sorry, go on.
Yeah, sure. Because I come from forensic background and I'm also an ethicist. So I sit pretty like on a wall trying to teach medical legal issues as well as ethics. So one thing that comes to my mind is both of them are meant for welfare of people, to have an order, to bring justice. But one is asking for minimal rules and regulations so that somebody gets justice, whereas ethics is exhorting people to do something more than that. So one actually cannot function without the other. If there is no law, probably we wouldn't even have the lowest possible things coming, because it is to be internally decided. Like Plato says, if we have in our own heart a court, we really do not require a court outside, right? But since we don't have it, we need to be regulated from outside laws. So they are asking us to do basic minimal things that is laid out. So whereas when it comes to ethics, we are not restricting to basic minimum, but we are thinking what can maximize benefit? How can it be given to everyone? So we are going a little beyond the call of law to expand the boundaries for the goodness, for have a social good distributed in a way, and for justice to be given. So that's my take on it. Thank you.
Thank you so much. Do any of the panelists want to respond? It's a really great answer.
Yeah, I think that's a great point. So let me just build on what Veena said. So, of course, the relationship between ethics and law is complex. So for the lawyers among us, you'll be familiar with, of course, the field of jurisprudence, which is very much centered on this question. But to pick up on what Veena has mentioned, essentially, of course, laws tend to be constructed in a particular socio-economic or socio-political and temporal context, and it needs to be revisited from time to time, and it tends not to have the sort of aspirational character that we find in ethical evaluation. So it is important that while societies may implement a particular legislation to meet particular goals, it needs to be constantly reconsidered, reevaluated, and to see how particular legal provisions will have to change. So, of course, if we find that in law itself, at a particular time, may have been considered to, from a utilitarian standpoint, be justified in creating greater benefit from for the majority. Of course, assuming that there would be safety net in place for those who fall out of the majority position, then it needs to be reconsidered over time as to whether it is still continuing to operate in this particular manner. If it is not, then certainly from a utilitarian standpoint, we have to revisit the particular law that's in place. So if, for example, in terms of say criminalizing particular activities and therefore resulting in underreporting, then there will be very serious ethical justification in revisiting the sort of legal provisions that are in place. Of course, what may be, as we find in some societies, on the books in terms of mandated reporting may in fact not be implemented in a very rigorous way, precisely because of the ethical dimension of this concern. So hopefully that helps to address a bit of that particular question, which is a complex one. So thank you very much for that too.
Great, thank you, Kelvin. Lisa?
Yeah, no, I think it's a really important question, and I think has to do, particularly coming from a world of infectious diseases, is probably one of the ones where this has been perhaps some of the most important. Starting, for example, with tuberculosis, but also with HIV. I think one of the questions that I have, which is, if we were to expect law to govern what else we do, that there are many things which in the health system we can do that are unethical but are still remain legal. And so I think we need to sort of think about these as supportive of each other, but hoping that the legal is sort of the bare minimum. And my interest is, how do we actually continue to change the culture and change the norms so that ethics becomes, ethical behavior in the same way that, for example, anti-racist behavior becomes what people do, as opposed to having to rely on legal or even things like IRBs to keep people in line.
And Pia, do you want to say any final words on this? Why do you have anything you want to add to this question?
Not actually.
Okay, great. Then we'll move on to the next question from Pio Justin. What is the moral obligation of the government to the population prior to the deployment of these novel interventions like contact tracing apps? Uptake of these apps on the ground highly depends on built trust with the government. Another thing, apart from the digital divide, access to mobile phones, which is the only means to use this app, is also a concern. Would that further aggravate existing access issues? Should that be an obligation of the government? Anyone want to begin?
Yeah, thanks very much. Sorry, let me speak again, Veena, and sorry to hog the forum in a sense. I responded to Pio. Thanks very much for the comment. So having originally come from Singapore, I think I could mention a bit about what's happening there. So at one point, of course, contact tracing app. In fact, I should say, sorry, to backtrack a bit. So contact tracing app has been used from the start of the outbreak. And as the outbreak became more severe in Singapore, particularly among certain subgroups that Pia mentioned, actually. That there was consideration among policymakers as to whether contact tracing apps should be made mandatory for everyone in Singapore. And of course, that resulted in concerns being addressed essentially in public online forums. And so I'm happy to say that, of course, through those forums and also through more active engagement, the government decided not to mandate the use of these digital apps across the entire country. So, which I think is sensible, and it does reflect what is broadly indicated in the international ethical documents, which means, of course, ideally, if time permits, right, you should have prior consultation with populations that may be affected by these technological change, and to understand what might be some of the concerns. And of course, and if these concerns could be addressed at the policy level, they should be addressed. But of course, if the matter is such that there isn't time to conduct consultation or effective consultation prior to the introduction of the intervention, then there ought to be ongoing sort of engagement and a constant evaluation of the sort of intervention that's being put in place. So this would also include things like digital technologies. So the underlying point I think to be made here is that particularly for public health matters, it's really crucial to sustain public trust and trustworthiness, because if your public institutions lose credibility, then you will not get buy-in from affected communities, and that will not help your public health situation. So I think that we have seen repeatedly in many different settings, and I think again for our current pandemic, it bears repetition. So thanks very much.
Calvin, you had mentioned that a lot of Asian countries did not pursue total lockdown. Was that because of the presence of the apps, or they, well, I guess I'm asking, what did they substitute instead, or did they did a balancing equation and did not want to have such a total effect on the economy?
Thanks very much for the question. In fact, it's difficult to generalize across all the various East Asian countries. While many have not gone into a complete lockdown, the reasons would be a bit different. So it can't be fully attributed to the digital tools that we have. So just to be clear, I guess we can all say that digital technology is not the silver bullet to the problems. It certainly is not. So it's a combination of factors. Certainly within East Asia, I think we can quite safely say that at least for the communities generally, there's been the benefit of experience with SARS. So a lot of individuals did not have to be told that you need to wear a mask. So particularly in Hong Kong and in Singapore, we've had very bad experience with SARS, and so we remember. So given that, there was already an automatic buy-in, so to speak, by communities. So individuals did not have to be told what to do. And I think at the ground level, it's very encouraging to see that people were even sharing masks with those who have masks were sharing with those who did not. So this was of their own initiative, and this sort of demonstration of solidarity, I think, is important. And of course, these sort of behavior, if you like, broadly speaking, should also be supported by a number of different public health policy measures. So that would also include, of course, then the use of digital technologies and social distancing measures to effectively make the public health goals more attainable. So I should say that ultimately, in terms of being able to avoid a complete lockdown, would be attributable to quite a number of these factors, and certainly not exclusively to the use of digital technologies. But that said, digital technologies help individuals get access to care of certain individuals, especially those with struggling with mental health issues, for example, or some chronic conditions. We find that telemedicine, for example, and the use of digital technology has been very helpful in this respect.
Thank you.
And thanks very much.
I just to sort of translate what Calvin said, it's a great response to sort of implementation research. You have this contextual factor, which was the history of SARS, which made masks much more acceptable. And so it would be a mistake to say, oh, well, it worked I know perhaps the most, South Korea, but also places like Singapore, Hong Kong, and say, well, why can't you just do masks in other places? It's really ignoring that contextual factor. So there was a level of community education that wasn't needed, and therefore you could jumpstart it. But it was also associated with other very important strategies to make sure the other evidence-based interventions like rapid testing, the social distancing was also rapidly put into place. And so I think it's a really important thing to recognize why some things were easier and other ones. It's interesting, in the US, one of the equity issues that we're actually actively working on is this concept of telemedicine, where we have a range of individuals, some of whom have not just smartphones, but actually computers or tablets that they can interact with their physicians, other ones who really only have the phone, and others who don't even have that. People are homeless, or people who are living in a situation in which they don't want to disclose what they're talking to their physician about. So there's a lot of other interesting things which the digital divide has become really a matter of really quite great importance for that. And so I think it's going to be an important question again about acceptability for use for tracking, but then there's other issues in which the access to digital technology is really quite critical.
Do you have anything to add on this question? Yeah? No? Okay. We can move to the next question from Dr. Savita, who said, what do the panelists think about the ethics of using alternative medicine, which has had proven benefits for COVID?
Did you say it has proven benefits?
Which has proven, I mean, Dr. Savita can clarify, but I think she means alternative medicine that already has proven benefits for COVID.
I see.
Dr. Savita, do you want to clarify?
Well, I think that makes sense what you said, proven benefits for other illnesses.
It says proven benefits for COVID. That's what the question says.
Okay, I missed that paper.
Dr. Savita, do you want to clarify which types of alternative medicine you mean?
Yeah. We have seen that, of course, I did not read the published research article on that in the medical journal, but I must say that there was, I do not want to name the researcher or the system of medicine. There was one alternative medicine which was for which they conducted a clinical trial, and they had proven that it was useful in the treatment of COVID. So what is I understand that, I mean, I may sound a little, what to say, may not be a very liked question in the panel or the population which is dominated by allopathic medicine, but of course, even I'm an allopathic doctor. But if there is research proven alternative medicine in for a pandemic like this, what would be the stake of the governments or the research ethics, people who work in the area of research ethics, to promote it or to bring it to the upfront?
I think one of the challenges, which is a really interesting one that you bring up, and I'm going to sort of say that it doesn't matter whether it's what kind of medicine it is, the concept of effectiveness. And I think one of the things that's been both a remarkable component, but also a tremendous challenge is the deluge of scientific evidence, some of which is not particularly good, that has emerged. And so I think for me, some of it is how do we not bring in biases of what we believe might or might not be work, but actually apply the same level of rigor that we would in determining whether or not something is effective, and making sure that that's actually good, so that you don't have people particularly people who are more vulnerable, going out and spending some of their limited resources to take things which either have no benefit or that reduce the chance of them actually getting things which are effective, or actually have things which cause harm. And so I think it's a very important question. I think it does bring in this idea about how to not bring in bias, but I think that the same lens has to happen. And it is remarkable in the sense of how quick the data is coming out. And that has certainly helped in some areas, but I think has really harmed in others.
Yeah, thank you.
Thank you, Lisa. Pia, Kelvin, do you have any comments to add?
No, I think it's a great point. Thank you. Yeah.
Yeah.
Yes, I think also along the same line with Lisa, that I think we have to balance the risk and all this issue that we need to take consideration, no matter whether it's alternative medicine or even new medicine or new vaccine and others. Yeah.
Great. The next question we have in chat is from Rodora. Would you think measures like forced quarantine or employment of militaristic actions on communities to control people are human rights violations? What would you suggest to remove these threats? These techniques may enhance stigma on persons just suspected of COVID-19 infection, including their families, and enhance fear and stress in the community. Kelvin, do you want to take this first? You look ready to go.
Thank you so much for the question. Again, it's a difficult question to answer, but certainly an important one to think about. I think broadly speaking, it's very clear that even when we think about very important public health interventions, or for that matter, any kind of state action, it must be respectful of human rights. So in a public health context, we see that in the international health regulations. Of course, it speaks to travel restrictions and a number of other restrictions. But even then, all of these actions directed at public health goals or collective interests must still be respectful of some very fundamental human rights expectations. So I think there's no particular disagreement on that. But of course, what becomes more difficult will be in terms of balancing the sort of interest. Of course, in a public health kind of context, we always tend to be faced with very difficult balancing of individual rights with more collective sort of interest. And then, of course, there are different approaches to it. Of course, in the law itself, if we are to or if a particular intervention is challenged in the courts, for example, then there would be a number of tests that will be applied to see if the sort of intervention is in proportion with the sort of the broader good that we hope to achieve with that particular intervention. But at the same time, I think that said, it does mean that even if there is a collective justification for an intervention to be taken up, there will be, at least certainly from a country sort of standpoint, very fundamental protections that need to be in place in order to secure the well-being of adversely affected individuals. So that would be my response to this question. Thanks very much.
Thanks, Kelvin. Lisa, do you have a response?
No, I think it's a very, very great response to that and about the balancing. And I think it goes back to some of the original discussions about community engagement and community discussion so people can understand, but also recognizing why there might be resistance. That is, some of the lockdowns, it took a huge amount of effort to figure out how could a woman in active labor be allowed out during a lockdown, or other types of things. So really having a very educated, nuanced, and communicative approach to when things like lockdowns have to happen.
Great, thank you, Lisa. Yeah.
Yeah, a very good question. I was actually thinking about the side on how to mitigate or how to reduce that. And one lesson in Thailand is that when we have a good system, at least partially, the labor law, some other social welfare system actually can help mitigate those kind of impacts. In a sense, like for example, in Thailand, if you're forced to lock down or company forced to close, then there'll be some compensation from the Social Security Fund that could be disbursed to help support those beyond what government paid to some of the others. So I would guess in a system, maybe we need to work together to design those kind of systems to help make it more just and at the same time effective. Yeah.
Tina, I have a quick question for the panel. Pierre, one of your slides showed the triple threat from COVID, the virus itself, the social distancing effects, and the economic burden. Now, for sure, some vulnerable groups who have will suffer the disparate impact of that triple threat due to pre-existing inequities. So actually, my question to you and also the other panelists is because they have been disproportionately burdened by the pandemic, and it may be difficult to try to modify those effects. So when we have a vaccine, should those disproportionate groups become a high priority group to get the vaccine? Now, I don't think I've seen that in any of the published guidelines for vaccine priority groups. What are your thoughts about that to try to address the inequities?
Hi, should I respond a little bit? Thank you, Henry, for this very, very important question. And I agree with you that this kind of what you call resource allocation policy that take into account the differential impact and risk could be one way to address and try to mitigate this. And I saw actually in your slide the four criteria. The fourth one is about if you can mitigate disparity, that's even better than just only three, but add the fourth one, and I think it's important. But even for this, not just about vaccine, but I feel that the current COVID pandemic actually help us see the issue, equity issues, the challenges that we are facing much clearer. It brings a lot of this into the front, and like Calvin mentioned earlier, this migration issue in Singapore received a lot of attention. A lot of change happened to improve the system in Thailand as well. One of my article tried to argue that even if we have universal health coverage that allow people to get medical care for free, a lot of social and societal aspects that need to be addressed beyond just access to medical care if we want to have a real better health equity. So a lot of this start to come up. People start to talk about all of this, and I think it one of very few good side that probably we could hope and try to build on if we really want to see a better situation afterwards. Yeah.
Okay, thank you. What about Calvin, Lisa? What do you think? High priority group for the vaccine
I think there's going to be a lot of factors that go into deciding it. And so figuring out how vulnerable or high risk is defined is going to be an important first step. So one could make the case that it's actually the healthcare workers who are in this context the most vulnerable and the most at risk. The others could be people who are not able to isolate, who are frontline workers, not in the healthcare system, but the people who are delivering the food, who are driving the trucks, et cetera. And it turns out that if you map that overlapping, there's probably a huge amount of overlap. We know that in a lot of the healthcare settings, for example, if you look at the, not necessarily the frontline health workers, but the people who are the supportive healthcare workers, their rates are very, very high. And a lot of it is actually community spread. So I think it really needs to be decided not who is the most deserving, but a very simple public health, which is who is at the highest risk, and vulnerability has to be defined within the context of that. And I think the challenge is going to be the balance of efficiency versus equity, and figuring out how do we actually make sure that the most vulnerable, the most at risk, even if they are not the easiest to reach, are afforded the vaccine, as opposed to, for example, just a first come, first serve, which will inevitably lead to greater inequity.
Great, thank you.
Yeah, sorry. Just to add to that, yeah, I agree with what Lisa mentioned, and just to weigh in a bit on the discussion, I think it may be helpful to emphasize again the communicative aspects and to be transparent and accountable. So, of course, we may be familiar with Norman Daniels' accountability for reasonableness approach, so which really emphasizes in terms of making these sort of prioritization decisions to be fair-minded, to be open, to be engaged, to be clear about the reasons for prioritizing in a particular way, and of course having avenues to revise the prioritization as we learn from our experience. So I think these will be important aspects to consider, certainly from an ethical standpoint. So thanks very much for that important question.
Thank you.
Yeah. I also like to share my viewpoint is that one thing is to balance between the risk and then the vulnerability, and also the key stakeholder and community involvement, and then to prioritize according to the need of the context. It's also very important. And then again, and then transparency of the decision, whatever the policy level is made, it's had to be delivered very community involved, all the stakeholders to be involved, so that that the people and community will be well accepted that this prioritization will be the not the best, but that will be the suitable choices, because we cannot provide everyone to get an equal chance. So weighing between the risks and vulnerable, and then also to make sure that all the decisions to be transparent.
Okay, good. Thank you. Thank you very much, everyone. Great.
Do we have any more time, or are we wrapping up?
I'm not wrapping up. That's up to you. I'm going to wrap it up.
I think there's a good question from Felicita. Can I ask you to read your question out, or ask your question?
Hi, thanks a lot, Veena. I think my question was more about how, we have these discussions on medical ethics or research ethics, but these things we discuss in the smaller forums, like among academics and intellectuals, whereas, when you talk about the way the media talks about it, it focuses a lot on the daily numbers that kind of worsens the inequity. Different people have different, I don't even know whether there's a term as, knowledge inequity. They don't really understand how the disease works. So how do we kind of bring what we're discussing here out to the wider public? How do we engage the media to make it a point of discussion? Otherwise, it kind of stays here, and the wider public, who are the people whose inequities are growing wider? Basically that's the question. How do we bring this to the media? How do we bring this to the wider public and policymakers?
I'll take this because then I'm going to actually have to log off. I think that's a very, very important point. And I think way back up in the chat, somebody said that ethics needs to be a multidisciplinary endeavor. And so I think, researchers are not particularly typically well known for their ability to communicate. And so understanding how do we actually engage the media, get them to sort of view this as an important event, but also how to communicate to the community so that they can become more empowered. How do we communicate this to the policymakers, and what are the levers that that they need to be convinced to pull to understand why this is something that is important, and to the politicians as well. So I think it's an very important thing for reasons that I'm not totally sure about. In Chicago, this was actually recognized extremely early, and it's become a really, really important talking point. Now, that doesn't necessarily mean there's been a lot of strategies to address it, but I was sort of shocked that, there's been tons of academic research on the diabetes, the undue burden of diabetes and obesity and cardiovascular disease, and it's never really hit the public, and somehow the disparities of COVID were picked up. And I don't actually know why that worked. I mean, it would be a good, important thing to understand. But it's really getting the media to understand why this is something that they should value, and getting the community to demand that kind of transparency, I think, is probably some of the approaches that might work.
Yeah, thanks very much. I may just add to that. I mean, great points from Lisa, whom I agree with. Of course, what's also interesting, I think, at least from this part of the world, is that there is actually a lot of information out there, and I think certainly for many academic institutions here, we do make it a point in terms of what we call the, broadly speaking, knowledge exchange activities in making research information more accessible. But I think what's interesting is why all this information is not being so well received as if you observed by certain members of communities or particular groups, even when information is out there, or perhaps it's some resistance in taking them on, or perhaps they're not capacitated enough to do anything with this particular information. So just relying on information alone, as we all know from I think many studies, that it's not enough essentially to meet the sort of public health objectives that we may have in mind. So I think certainly a lot more room for research in terms of understanding ourselves, I think, as researchers, the way that we're doing our work, right? Is there perhaps a disconnect with some of these communities? Why are we not able to reach out to them? Why are we not communicating as effectively? And what are some of the barriers in terms of them understanding the sort of information that's coming up, or perhaps doing something about it in ways that could capacitate either themselves or communities? I think this would be a great opportunity for reflexivity, I think, in terms of thinking critically about how we do our work as researchers, particularly in ways that are intended to alleviate the inequities that we observe. So thanks so much for the great points.
Yeah, do you have anything to add?
Maybe a little bit on our experience. One part of the work that we do at National Health Foundation actually is to create a platform where we bring in both researchers, academicians, policymakers, and as well as media to come together to discuss on critical issue. And I guess this kind of thing probably could be one opportunity, but it's just one of the example of a small initiative that we do to try to engage different stakeholders, even in many cases from the beginning of the research work. That's some of the very important policy research work that we try to initiate. It has to have that process starting off first, and I don't know. It may be one of the potential way that we can create more buy-ins and more interest in this kind of issue. Yeah.
Okay, thanks a lot for those perspectives. I mean, I think though, if I could just express my thoughts. There is some stigmatization of people who want to talk about the iniquities, because there's this great fear that surrounds COVID and the need to curb it, to curb the disease itself, that I think there is some unwillingness to look at the widening of iniquities through the implementation of the policies right now to try to curb the disease. But I do agree with all of you that perhaps it's got to be something that we start when we start the research itself. So thank you.
Yeah, you ask a very good question about the policymakers. Very good question. Thank you.
We can take 2 more questions, I think, Henry, and then we can call it a day for the panel. We only have 2 panel members left, so I think that sounds good. And these questions came in a while back. So, Dr. Johnson, do you want to go next with your next question?
Thanks, Veena. My question is to Calvin. I think not only in India, I think most parts of the world, we are all facing a problem where as a IEC members or a research committee members, do we meet online or do we meet offline, like face-to-face, and then take a approval? For example, when we ask the same questions to our Indian counterparts like ICMR, they were not able to answer it. They were not very clear about whether can we take approved studies online on a online or a digital platform, or it has to be face to face, especially clinical trials or studies related to vulnerable patients. Calvin, I think, can you answer me on that?
Yeah, thank you very much for the very important question, Dr. Johnson. I mean, thinking about it's again difficult to generalize across different systems because as you've perhaps alluded to, there will be the social cultural dimension as well. So perhaps in some settings, a face-to-face meeting would be more effective in eliciting particular concerns from individuals who may not otherwise feel comfortable speaking via an online platform. And as you've mentioned, for high-risk studies, it is important to understand all the concerns that ethics committee members may have. So especially those who are familiar with, say, affected communities or communities who will be participants in that particular study. So it's very important to give voice to these individuals and to understand what these concerns may be. So I'll be in full agreement that if in your particular setting, in the way that, let's say the setting that the particular REC works in, if a face-to-face kind of interaction, circumstances permitting, is more ideal in sort of drawing out these concerns, then I think a face-to-face meeting should be the way to go. And if at all possible, say for example, a face-to-face meeting at this stage is not possible, and if the research itself is not urgent, then perhaps the situation could be explained to researchers to say why exactly this cannot be done and the decision could not be reached at this point. And I think researchers will understand some of the reservations and ideally should cooperate and work together essentially with RECs to address these concerns. So thank you so much again for the opportunity to share on this.
Yeah, do you have anything to add on that comment? Okay, great. I just want to check with Rodora. Are you here? You have one more question? I'm not sure.
Yeah, right. You just read it, please. How do we prioritize needs of communities impacted with multiple problems, and how do we modify the implementation research? And if we have research on COVID-19, but the people or the communities are impacted with multiple disasters like super typhoons, of massive floods. So how do you do that? Do you stop the research on COVID-19? You know that the priorities will already change with all these disasters that impact on them. Anyone can answer?
Let me have a go at this, and then we can hear from Dr. Pia to see if he's got anything to add to that. So, Rodora, thank you very much for the question. It is very challenging, and it certainly was a matter that came up during the Ebola outbreak as well. As you know, that outbreak occurred in the context of societies in civil strife. So there were multiple challenges. And in terms of prioritization decisions made there, it should ideally, again, be supported by active community engagement. So we need to understand what the concerns are. We need to understand, at least from the standpoint of the affected communities, what's important to them in terms of what ought to be addressed first. And to see, of course, also the sort of capabilities that we have in addressing these sort of concerns. So it is a difficult question that will require a more detailed sort of discussion, but you may like to have a look at the WHO guidance document on outbreaks. So there are a number of interesting points to consider, or I should say not just interesting, but important ones. And it would be great to get feedback from you in terms of what you think, whether the document itself is helpful or not. So that would be at least my initial response to that. Again, very important in emphasizing whatever actions that we do should be ideally trust promoting. And if we say trust promoting, it would mean essentially addressing the sort of needs that the community would prioritize themselves. And these would typically be, at least from previous experiences, in relation to very immediate health sort of needs rather than research objectives. So hopefully this helps to start. So over to you, Pia.
I'm afraid I have nothing more to add, but thank you, Calvin. I would guess I totally agree with you, this community engagement and the issue about implementation research, how it can be employed to help you address this even better in terms of responding to the real needs and others. But it's a practical challenge sometimes with this dynamic situation. And when we think about systems, not just a problem or a specific issue, then this kind of research to try to address system level would probably be something that we should try to engage and do more. Yeah. Sorry, you don't have the any add to that.
Great,
That's brilliant. Thank you.
And I think that should be the last question. And because I think we're already 20 minutes past our time limit, we can end it there, Henry?
Yeah, no, that sounds good. Excellent. Very good. This was an excellent session. I want to thank all the panelists. As I said before, it's going to take me several weeks to wrap my head around all these wonderful ideas. So thank you very much. And thank you, Vina, for moderating all these wonderful questions. So our next session will involve the community engagement and implementation research. So I think that will be a natural follow-up to this session. And we have Christina Torres from FERCAP, who's gonna start off with the presentation. So how many minute break do we need? Would we all like to take? 20 minutes? Is that? I'll ask the question, then I'll mute everyone, and if everyone does not disagree, then how does 20 minutes sound? And Vina, I think, agreed, even though I didn't hear her. Okay. All right. So why don't we come back? Well, why don't we come back at around 1:45 a quarter to 12, right? Is that right?
1. Quarter to 1.
Oh,
Quarter to 1.
my time. Okay. All right. Sorry. Thank you. Quarter to 1. Well, forgive me. Quarter to 12 sounds a little bit better for me, but anyway, okay. Quarter to 1. Okay. Excellent. All right. Well,
All right.
any other issues? Okay. All right. So again, Pia, thank you. Calvin, thank you. Wei Wei, thank you very much. Vina, thank you. Excellent. Very good. Okay. All right. Well, see you back in about 15, 20 minutes. Okay. Great. Thank you. All right. Okay. Christina.
Yes, I'm ready.
All right. Are you presenting your slides?
Yes, I'm putting it on now. Can you see it?
Yeah, there it is.
All right.
Very good. Excellent. All right. Dr. Kintet, how are you?
Yeah, I'm fine. How are you?
All right. Very good. Excellent.
Yeah. So let's listen to Christina.
All right. Is everybody back? Well, why don't we give it another few more minutes?
Okay.
Only 65 people are back, so you know how it is with these breaks. All right. If you guys are back, show your video. You could turn it off if you want afterwards. I just want to have a sense. All right, people are coming back. Give it another couple of minutes. I think this is working out really well. The logical sequence. We talked about community engagement, right? Implementation science, and you're going to wrap it up for us. Okay.
Yes, that's a good chance.
Yeah, that's right.
So, should I begin?
What's that?
Should I begin now?
What do I think so. Yes, right. So, Christina, why don't you introduce yourself to this wonderful crowd? I'm sure everybody knows you, but
yes, I'm a social science professor.
Is that it?
No, not everybody knows me.
All right, well, tell us some more.
Yes.
All right. And where?
All right. I'm a social science professor. All right.
Yeah. Go ahead.
Sorry?
What institution are you with?
All right. From the University of the Philippines. I'm currently, have retired. So I'm currently chair of the Bioethics Study Group and adjunct faculty at the National Institutes of Health in the Philippines. And I'm a Department of Health consultant for research ethics, and I am the FERCAP coordinator. So I'm going to talk about ethics of community engagement in implementation research. And I think we adopted a very logical flow of speakers because many of these things have been discussed in the earlier panel, but now I'm going to talk about ethics. I would just like to disclose that I am not a bioethicist, but I am an IRB specialist. And therefore, if you have questions about IRB operations, then maybe I would be able to answer these questions. Now, when we are doing implementation research, much of it is coming from the social sciences. And very often, social scientists complain that ethics committees medicalize their protocols. And therefore, I think it's very important for us to understand what are the contributions of social science related to ethics, particularly if this is about the community and if this is about implementation research. So my outline, I'm going to define the terms. I think implementation research has already been defined earlier, but I'm going to define community. I'm going to define social value, which is an important value in SEOMS, and I'm going to define ethics. And I have a little discussion about common types of implementation research that was discussed earlier by Lisa. What are the common methods? But the focus of my discussion is about ethical issues related to implementation research when you are doing it within a community. And I will discuss the 3 stages. What is the preparation that you're supposed to do? How do you implement it? And what are the ethical issues when the research is over and you are in the post-study phase? So just to repeat, what is implementation research? It is an integrated concept that links research and practice. And therefore, when we're talking about COVID, it's very important that we link research with practice, so that you will have good delivery of public health approaches. It addresses the challenges of know and do gap. Now, many of us know, but we do not know how to do it properly in real world settings. So it involves the creation and application of knowledge to improve health policies, programs, and practices. And it uses multiple disciplines and methods to emphasize partnership among community members, implementers, researchers, and policymakers. I think the earlier panel showed us there's a health economist, there's a lawyer, there's a social scientist. All of them are familiar with implementation research. And I think that's a very important concept that we need to understand when doing implementation research. We cannot be very conceptual, it has to be applied. So I would like to define community, what community means in the social sciences. Very often, we think of a community as a group of people with diverse characteristics in a geographical location. However, community in the social sciences is not necessarily geographical. It may be a group linked by social ties, share common perspectives. An example of this will be a migrant community living in their new home country, or it might be a group engaged in joint action like an NGO, or it may be a people in the same profession such as medical doctors, social scientists. So that is the concept of community in the social sciences. So when we talk of community engagement, it is not limited to a geographical area. It could take into consideration the various types of communities that we are trying to target in implementation research. Now, in implementation research, social value is very important. And social values are a set of moral principles defined by society, dynamics, institution, traditions, and cultural beliefs. For example, the way you do research with American Indians is going to be different from the way you do research with Asian Indians, because the moral values, the traditions and cultures are different from each other. And the framework of implementation research, because where context is very important, social values becomes an important component of the framework in implementation research. These values are implicit guidelines that provide orientation to individuals and organizations to conduct themselves properly within a social system. So implementation research focuses on practical approaches to improve implementation, to enhance equity, efficiency, scale up, and sustainability, and ultimately to improve people's health. But again, I would like to emphasize it is context specific. And context is defined by the social values of the community where you are doing research. So what about ethics and social values? Ethics here in my presentation is meant to mean normative ethics, and it's concerned with the content of moral judgment and criteria for what is right or wrong. But normative ethics would be under the framework of social values, which are desirable social conditions that provide general guidelines for social conduct. Please take note, they are culturally defined goals that provide aspirational reference. Social values define normative standards of social behavior derived from social interaction and accepted as constituent facts of social structure. So it's very important that we understand ethics and we understand social values of the community where we are doing the research. Now, there are many types of implementation research. It can be for management improvement. It can be for operational research, which is different from operations research. When we talk of operations research, we're talking of mathematical models, but operational research is how you implement a particular program. Or it can be policy research, program evaluation, dissemination of evidence-based medicine, or I think in terms of community engagement, participatory research is most important. And what is the definition of participatory research? Where the participants or community is involved from conception, implementation, evaluation, and action plan. No? In WHO, several years ago, their focus was on community-directed interventions. No? But now, TDR is talking more about implementation research. What are common methods used? In the social sciences, there are only two generic methods. It can be quantitative. The objective is to come up with generalizable data, or qualitative, where the final outcome is about insights. And therefore, you make use of key informant interview, focus group discussion, ethnography, which is about observation, or you can use mixed method. One part is qualitative, another part is quantitative. But at the same time, the social sciences would derive some methods from biomedical research. And therefore, we talk about the quasi-experimental method with intervention and control arms. For example, in COVID, if you are doing a vaccination study, you choose one province, province A, as the intervention site where you are going to use an experimental vaccine. And you compare the results with province B, and province B would receive placebo. So you have an intervention arm and a control arm, and later on you determine which place would have better results. And usually the design of these studies would be cluster randomized public health interventions. Now, public health has much to do with public administration. After all, you have a Ministry of Health, you have agencies, government agencies, and they're all part of public administration. And the U.S. National Association of Public Administration would define the 5 E's, which will provide the standards for evaluating any public administration or public health programs. The first ones would be economy and efficiency, which is about money, which is about cost. And if you are a financial agency, then there's very high emphasis on economy and efficiency. However, you are in public administration, effectiveness becomes very important. And what is effectiveness? It is about the mission of that public agency. And therefore, that is the social value, and you focus on social goals. For example, the social security system may be interested in economy and efficiency, but the bottom line is that it must provide security to its citizen. That is the mission, and therefore effectiveness becomes a very important standard that has to be met by any public agency. But at the same time, there are other two E's, no? And that is equity. And earlier we were talking about vulnerability. And equity is about the absence of social disparities. It also means access to services. No? So you may be efficient, but it results in exacerbation of social disparities. And therefore, equity is sacrificed because you focus on efficiency. So these things need to be balanced. And then, of course, the fifth is ethics, which is about legal and moral conduct. Now it's becoming part of public administration to look how ethical we are. And of course, there are different guidelines. The Belmont Report will talk about autonomy, beneficence, and justice. But SIOMS talks about social value, scientific soundness, and also ethical soundness. So these 5 E's need to be balanced. No? And if you're talking of ethics, equity and ethics are very much related to each other because we address vulnerabilities when we focus on equity. So, why should the community be involved at every stage of research process? Now, because my talk is about community engagement. You need to involve the community so that they are represented in research. And participatory research would say that you consult them about the design, of your protocol. You consult them how it should be implemented. You consult them on how evaluation is going to be done. So the community is at the heart of this approach. And essentially, it's more likely to succeed if the community is involved. And it's more likely to be effective because you got inputs from them. They're the best people to pass judgment on programs that are being done about them and with them. More likely to build trust with the community. And I think the goal is that the community should have a sense of ownership, and that should make implementation research sustainable. So at the end, it is no longer your project, but they have taken over your project. And that is what we talk about when we discuss community empowerment. And community empowerment, I think, is a very important component of implementation research. Now, in my discussion, I'm going to talk about the ethical considerations in research, and I follow these 3 stages that has been suggested by this article, where you look at the ethical considerations during the planning period. That is when you prepare your protocol. A protocol is not something that you prepare overnight. There are many things that you have to plan out for when you are doing implementation research. You need to know the target community. You need to know much information about the context in which you are going to do this research. And that should already be incorporated into the protocol during the planning phase. So in the planning phase, it's a researcher who prepares a protocol. You submit it to an ethics committee, and the ethics committee is going to look at the ethical issues that are involved in your research plan. And that becomes the basis of risk management, risk assessment, and risk management. The risk factors defined in your protocol, are vulnerabilities defined in your protocol, because you will not be able to address these factors if they are not identified in the protocol. So planning phase for a research ethics committee is very important. And based on a protocol that has been approved by an ethics committee, then you conduct that research, but it is the responsibility of the ethics committee to monitor the implementation phase, so that you have to do the protocol based on what has been approved by the ethics committee. So, but it does not end there. No? In the planning phase, you have to say at post-research phase, what's going to be the benefits to the community, and that is incorporated in the planning phase as well. So even after engagement with the community, if it has been planned well, then the post-research phase would go on. And essentially in the post-research phase, we're talking of community empowerment or benefits to participants. How does it become sustainable? So these are very important stages in implementation research, particularly when you are dealing with the community. So let's take it up one by one. So the planning stage, I would say that is the stage when you prepare the protocol. And the first thing you have to look for is responsiveness to the local needs and priorities. And when you talk of responsiveness, the starting point is the community assessment of their needs. Are there unmet needs? So this will involve the community. And is there epidemiological data to justify that you're going to do this research in this particular community? So responsiveness to local needs is highest priority when you are planning a protocols. So it's not about you, that you want to try this new medical intervention. Yes, but in which community are you going to do it? So responsiveness is a very important factor. At the planning stage also, very important is if you are able to determine the situational or contextual equipoise that justifies the conduct of implementation research. In clinical trials, we talk of clinical equipoise. In COVID, we talk of clinical equipoise. We do not have interventions yet that is found to be effective for COVID. And therefore, you can undertake more riskier interventions because you do not know whether this is better than nothing. But in implementation research, as I was explaining earlier, context is very important. What is meant by contextual equipoise? There remains genuine doubt whether a new and untested package of intervention will work in a specific context. You take the example of a COVID vaccine. Maybe it can work with Caucasians, but how sure are you it's going to work with Asians? Maybe it works in a first world environment, that you have to keep it in very low temperatures. But do you have such environment in a tropical country where we are in? So it's about context. Where are you going to do it? Which is the target population? And to justify implementation research, equipoise regarding the effectiveness of the implementation processes must be preserved. In other words, there's no data yet that will tell you this works, but sometimes it's context specific. It worked in other countries, but you are not sure it's going to work in your own country, where things are different, where culture is different. And that is what we mean by contextual equipoise. Then we look at study design. We ensure that scientific standards are maintained. And here, as I was saying earlier, many social scientists complain that ethics committees medicalize their protocols, because it is seen from the lens of biomedical research. But social science research is different. So we have to understand that research involves multiple disciplines with different ethical concerns. And therefore, in FERCAP, we always say that a primary reviewer should have expertise related to the protocol. So if this is a social science protocol about community engagement, you need a social scientist, who has done research with communities to be able to pass judgment on that protocol. And of course, in the social sciences, what is the appropriate methodology? Should it be quantitative, where you do survey with close-ended questions and you administer it randomly to a population? Or is it about qualitative methods where you go in depth and you try to understand, the perception, the culture, the traditions of the people that you are interviewing? And therefore, qualitative methods, the outcome is going to be insight rather than generalizable conclusions. Or are you doing a cluster randomized trial with intervention and control groups or step wedge approach? Meaning here, for example, in a vaccination study, you choose two communities. In one, you administer an experimental vaccine. In another, the control group, maybe you administer another type of vaccine, and then you test where COVID is going to get controlled. And you do it in step wedge, meaning you do not do it simultaneously in all the communities, but you do it to two communities at a time. And whatever learning you got from the first set, then you apply it to the next set, so that it has an adaptive design. But of course, there are ethical issues also because you are depriving the late communities from the benefit of early interventions. So all of this would have to be assessed, particularly by the ethics committee. Is there random allocation? Because that's very important in biomedical research. Without consideration of the specific needs and vulnerabilities of the participants, it raises concerns about justice and equity. Supposing you will have a successful vaccine, I think I heard that question earlier, to which community will you do it first? Who will have the first try, of this new vaccine? Or is it going to be done randomly? Or do you base it on needs? So these are ethical questions that would have to be addressed. And it should be justified why you prioritize one group over another group. Planning stage. And here I talk about social preparation. And that is about stakeholder and community engagement. I remember I was in Indonesia one time and they were doing the Wolbachia study. That was about the mosquitoes that are genetically modified so that when they mate with other mosquitoes, the dengue virus is no longer there. And they wanted to release this mosquito, in some communities in Indonesia. It was a very controversial protocol. The informed consent was that the household head, they go to one house, which they randomly choose. And then they will ask the household head, do you allow us to release the mosquito into your house? Or he says yes or no. If he says yes, then they release the mosquito into that house. And the issues were, suppose that mosquito travels to the next house, which did not give consent. So many issues like this. And therefore, for that particular study, the research group eventually got some sociologists, some social scientists to undertake the social preparation even before that protocol was implemented in this community. So that is stakeholder and community engagement. Communities and individuals with specific roles are important stakeholders to engage with. What is their perception about the Wolbachia study? Identify health priorities to identify key participants. Communicate transparently and effectively about the goals, design, risks, benefits, and process of a proposed intervention. Gain trust and develop partnerships to ensure a successful study. Get feedback and identify unforeseen barriers that could be mitigated at the planning stage. So in that study, the social scientists made a study about the social structure, the culture, the traditions, so that this could be addressed. And the issue was how should informed consent be implemented. And eventually, they decided that they will call for a community meeting. Now, the issue was, should it represent all households in the community so that they are going to make a consensual decision, or should it involve only a majority of the households in the community? So these were the issues, related to informed consent in doing that study. But of course, there was pressure from the local authorities to do that study in specific communities. So part of community engagement is to consider the power differential between the researchers and the community. So this is very important component of vulnerabilities. Allow adequate representation of the research participants and the community at large. For example, I know that in HIV studies, it is a standard procedure for US researchers to get a community representative that's going to advise them on how the protocol is going, an HIV protocol is going to be done in a specific community. Select community representatives to facilitate communication between the researchers and the community. In Thailand, for example, in some ethics committees, they have a community representative that sits in the ethics committee so that he is able to advise on how it can be done ethically in specific communities. Engage with vulnerable groups, the disadvantaged and marginalized throughout the research process to ensure equitable participation. I've seen this happen in some IRB Thailand, where they are doing many researches about refugees, migrant population, and therefore it was quite important to get a community representative to sit in the ethics committee so that it is done in a manner that is respectful of the vulnerable groups. Planning stage happens when you prepare a protocol, and as I said, this should not be done hurriedly. You need to understand the target population, the target community, and then you prepare your protocol, and of course this is submitted for the IRB to review. After all, the IRB will only review a research plan. And therefore, at the planning stage, you need to think about balancing the risk and the benefits. Conduct diligent situational analysis during the planning phase of implementation research to identify potential risk before harm is done. And risk is not only about physical risk. It can be social risk, it can be economic risk, it can be psychological risk. So there has to be a comprehensive evaluation of the risk that is involved in implementation research. Implementation research cannot knowingly expose one group to harm or significant risk for the benefit of another. I have seen researches about HIV prevention among sex workers, but you just cannot expose them to harm. Risk assessment is an important function of the researcher and the IRB. And this risk should be mitigated. And we say minimize the risk and maximize the benefits of research. Involve stakeholders in comprehensive risk assessment, which are physical, psychological, social risks like stigmatization, and plan for risk mitigation. That should be part of the protocol. The Declaration of Helsinki has mandated that there has to be an ethical consideration section in the protocol, and these are the things that need to be addressed in that section of the protocol. Also, there has to be balance between risks and benefits. Identify benefits at two levels. What is the benefit to the participant? What is the benefit to the community? Plan how to maximize benefits to participants in terms of maybe doing health promotion, education, sharing of results. That's very important in community research. Plan for community benefits like community infrastructure, capacity building, and ensure that there is a favorable benefit-risk ratio. So the next stage is about implementation. And here, very important is the informed consent process. Presumably, it has been subjected to prior IRB review of the protocol. And here we have to think of what is the appropriate type of consent. No? Is it oral? Is it written? Do you require signatures? What? Would you be able to give waiver of consent for minimal risk interventions directed at the community? And the example I can think about is, putting fluoride into your water, and that is a community intervention. And it is not. It may not be necessary to ask every member of the community whether they will consent to have fluoride in their water. It has to be community consultation. Dual consent of the gatekeeper, we call that permission, and the individual participant. They have to go together, just cannot get the consent of the gatekeeper. Randomization done at the cluster level in cluster randomized trial, and participant, and here the participant cannot choose which arm to join. So if you are intergroup, if you are in province B, you are the control group. You cannot choose where you want to go. So the ethical issues would have to be analyzed as well. Need for community engagement to determine the appropriate type of consent. Privacy and confidentiality, necessary when accessing records at a health facility. Informed consent is required when data needed has identifiers. In other words, you know the name, you copied the name, and yet you were given a waiver of consent. Waiver of consent may be given if data is anonymized. Determination is done by an institutional review board. In most of Asian countries, it's like that, in accordance with data privacy laws. Standard of care or prevention. Determine the appropriate intervention versus non-intervention in the control arm. For example, if this is a deworming study, in a filariasis area, you give the interventional drug to one group of school children. But what about the control group? You do not treat them? Is that justifiable? So these issues would have to be evaluated. Determine if local de facto standard of care of no treatment is ethical, particularly in low-income countries. Provide the local de jure standard of care or prevention as agreed upon by public health experts that is acceptable to the community. For example, if this is about deworming, maybe the herbs, or the fruits that they use for deworming will be given to the control group, and then the new drug about deworming will be given to the intervention group. You just cannot leave out the control group to having no access to any kind of care. Check if prevention measures are sustainable after the study is over. Ancillary care, what does that mean? It refers to the identification of problems that may contribute to ill health that are beyond the scope of the study in question. So there is ancillary care obligations when there is a serious or urgent need where provision of care may be within the scope of the research. Example, you are testing a diagnostic tool for COVID, but you are also university hospital researchers. And therefore, there has to be ancillary care that those who were found to be positive should be referred to care. Determine which needs fall within the responsibility of the researchers and the institution. Not only what type of researcher you are, but to which institution you belong. There is institutional responsibility to provide access to care. Proactively engage with the local government or NGO during the planning and conduct phases of implementation research to identify who will be able to meet the other needs. For example, in a study about violence against children. The ethics committee required the social scientists to refer the children who are who experience violence from their parents, that they have to be referred to a local NGO or to the social welfare agency so that they can be protected from their parents. So that's an example of ancillary care. Referral to care is a basic responsibility of the researcher. So you just cannot say, but I'm just, I am not a medical doctor. I'm just testing this diagnostic tool, so I cannot give them treatment. No? It's not ethical to say that. You still have to refer them to care if they are found to have a specific type of disease. Research capacity and health system strengthening. And here, this is the other word for community empowerment. Create trained researchers and volunteers, and capacity building of research experts to conduct implementation research in the future so that they are able to take up the work that you have done in the community. Facilitate appropriate stakeholder engagement, ensuring commitment by donors, the governments, to build sustainable research capacity. IR should enable scaling up of post-interventions, enable horizontal integration of public health interventions into the health system. What does that mean? It means that it cannot be the top-to-bottom approach, but people in the community would be able to take up the public health interventions that you have initiated and translate research findings into health policy. Post-research phase, there is an ethical obligation to disseminate the research findings widely, and this is where publication is very relevant. I think it was mentioned earlier, there's very little study about health inequity in Asia. Most of them are coming from foreign countries. Provide feedback to the communities and stakeholders who participated in the research. Publication of research is necessary to enhance resource utilization globally, and IR findings are presumed to be generalizable that would obviate the need for new IR studies in scaling up of the intervention in similar contexts. In other words, there are lessons to be learned from implementation research, and publication is necessary so that it becomes available. Your interventions, successful interventions, becomes available globally and very relevant to similar contexts. So dissemination is very important. Data ownership and sharing. It should be fairly negotiated through transparent stakeholder engagement in the planning phase of implementation research. But essentially, if it's implementation research, they're not interested in patent, They're not interested in having solo ownership of this particular methodology, because that's against the principle of community engagement. But still, there has to be ethical oversight of the data ownership process to ensure access by relevant stakeholders at post-study, provide access to local researchers and communities when appropriate, maximize the utility of the knowledge that is generated. Translating findings into public health action. So this is now translational. Researchers should propose actionable suggestions based on the research findings, facilitate uptake and scale up of successful interventions, suggest further study of identified barriers to develop strategies to overcome them, communicate with policymakers, educate the public about social justice obligations to meet rising expectations. Scalability and sustainability, very important at post-research phase. Ensure effective engagement during the planning and conduct stages of implementation research. Ensure that policymakers, local providers, and health system officials remain committed to sustaining implementation of an intervention if found to be effective. IR should have a sustainability plan to prevent exacerbation of inequity and harmful effects to the community, as well as loss of trust in the health system. Benefit sharing. There is an ethical obligation to share the benefits of IR with the community. I remember when we were doing research in some province in the Philippines, and we introduced ourselves. We're from the University of the Philippines, and they said, "Oh, here you are again. You are only using us as data sources. You never share the results with us." No? And of course, we have to do something about it. No? And we had sessions where we presented to them what are our findings, and then we asked the community, did we understand you correctly? Is there any correction that you want to make related to our findings? And they openly spoke up. No? So the benefit may be direct as a result of an intervention being studied, or indirect and not related to the intervention per se. The benefits may accrue to the individual participants or to the community at large. Advocate for sustainable translation of research findings into action. That's how we share the benefits of research to the community. So finally, I would say that ethical implementation of research will require socially committed researchers, that you understand the nitty-gritty of the target population. It also requires knowledgeable and competent IRBs, that will make appropriate recommendations, rather than prescribing a methodology that they would want the researcher to do. It is also about open-minded policymakers, who are open to prospects of community empowerment. And of course, the final result will be empowered communities who would be able to take action on similar circumstances that will improve the health of their community. So this is my last slide. Thank you for listening to my presentation. All right, so what's next? Henry, are you still awake?
Henry, you need to unmute yourself. Henry, you need to unmute yourself, Henry. Please unmute. Henry, you have to unmute yourself. Yeah.
All right, thank you. Thank you. That's very comprehensive. Thank you. Any burning questions from anybody? Okay. Well, I think we'll have the case study and then come back and address questions. So now it's time to go into those dreaded breakout rooms where you never know who you're gonna meet. So anyway, does everybody have the case study on their computer? So you could download it once you're in your breakout room. Does that make sense? Okay.
That's about the nomadic population.
Yeah, that's right. The vaccines and mobile GPS stuff, right?
Yeah, correct.
Okay, all right. So there's I don't know who do we have here for facilitators, but we have several people here, Zozar and Kinmar and and of course Christina and Vina, and who else? Who would like to be a facilitator? Nah, I'm just kidding. All right, so there's about 100 people, and why don't I do 12 groups? I mean, I think 10 people is a little large, right? So let me put you in your breakout room. So we'll have, what did I say, 12 rooms automatically. All right, I'm creating the rooms. Now, you're going to see something on the bottom of your screen. It's going to say, join your breakout room.
There's a question, Henry. Maybe I would like to answer that. What's meant by open-minded policymakers?
They don't exist. I mean, like, what kind of question is that? All right, Christina, answer that.
Yeah, I think open-minded policymakers are those who know what are the social goals of their program, and I was speaking of the 5 E's, and they should learn, how to make it equitable, how to provide access to the marginalized, so all of those. So you have to be open-minded. We say that in public administration, the important component is effectiveness. Effectiveness, what is the goal? What is the mission of your agency? And you should be able to prioritize that and include all the E's, But sometimes you will have some balancing to make, and I think equity, ethics, and effectiveness are more important in a public health program than economy and efficiency. They are important, but I would focus more on effectiveness, equity, and ethics. You should realize that in public administration, we have such a course like development-oriented mindset, development-orientedness. And that is what development-orientedness means. That if you're a policy maker, you understand these values and you know how to prioritize these values so that you are able to achieve the goal of your agency. That's open-mindedness for me.
Okay, I like that. All right, very good. All right, so
there's another good question.
Yes.
Sorry, Henry. There's just another really good question on the chat group that I thought just maybe before we go and break out. Christina.
Yes. What's the question?
Community engagement.
Whether ethics committee stresses enough on community engagement in protocol review.
I would say yes, particularly if this is implementation research, if this is social science research. Community engagement is very important because that is where we address vulnerability. And vulnerability is a very important principle that we have to analyze in ethics review. And also it's related to risk and it's related to benefit. Minimize the risk, maximize the benefit, which means we understand the context, we understand what vulnerability, what type of vulnerability is involved, and who is the best who is the best group that will tell us about that. That's the community itself. That's the community itself. That's why I emphasize on social preparation. When we are doing researches that are about community engagement, there's need for social preparation, that we understand the structure, the values of the target community. So yes, my answer is yes.
And you look for that when you accredit IRBs?
Yes, no? Because in FERCAP, we're doing accreditation of IRBs. No? We look at the type of protocol. And one of the things we require is that there has to be a primary reviewer with related expertise. And we evaluate the quality of review. We do board observation. No? We also do document review. And when we find out that these things are missed by the ethics committee, then we write that in the recommendation that they should have training in vulnerability, they should have training in social science research, they should have training in public health research, because many of them are trained in biomedical research, no? But not in public health and not in social science research. No? So we recommend such training so that before they are even given accreditation, then they already understand what the issues are and they are able to implement it.
Right. Yeah. Good point. Good point. I think most of the important research in the region is social science, but
yes, and public health. Public health is very important in the region.
And, but as you said, most members are biomedical.
Yes, they're clinicians. No? Most members are clinicians. No?
Right.
And many times the comment is not relevant.
Right.
The recommendation is not relevant. Yes.
Right. Yeah. So we'll stop picking on them. So
one last question.
Okay. Yes.
Yeah. Taurus, it was a fantastic presentation, and we learned a lot of things from your presentation. My one question is, what about whistleblowing in community research? Because sometimes there can be unethical research happening. So how do we take care of unethical issues? Like, can there be opportunity for whistleblowing?
Is whistleblowing what? A practice, or is it research? You know? Because when we talk of research, there's a protocol. You know? There's
no, not as a research, as a kind of a quality check, or a kind of some kind of a mechanism to make sure that if there are any issues, the participants have a voice to tell the ethics committee members or any other members in an anonymous manner, so that they are not identified. So
yes,
it's going to be a challenge in a community research, like.
Right. In the FERCAP standard operating procedures, we have an SOP about complaints coming from participants, you know, and it says that participants, that's why in our format of the consent form, the name of the IRB is there, the contact person in the IRB is there, and participants can call, you know, the IRB to complain. So 2 names in the consent form. One is the name of the PI, the principal investigator. The second is the name of the IRB with a contact number. And they can use that to call the IRB to complain about anything, no, related to the conduct of the study. We also require that researchers should keep participants should keep a copy of their consent form, you know, so that that becomes basis for them to say, oh, my rights were violated, they did not do it properly, and then they can complain to the ethics committee. So, and that complaint has to be taken up by the ethics committee. Depending on the complaint, if it is a serious complaint like fraud, you know, then it is taken up in the board meeting. You know? So depending on the magnitude of the complaint, it can be expedited or it can be taken up at full board. We have that mechanism in the standard operating procedures.
Thank you.
Okay, very good, excellent. So let's all come back at a quarter after the hour. All right. So why don't we look at this? So what are your thoughts about community engagement here? What purposes will it serve?
Henry,
yes.
Yeah, our group, we consisted of Dino, Veena, Dr. Pooja, and Dr. Aarti also. So we found that there should be community engagement even before the starting of the first vaccination. We feel that was missing in this study. So we feel that there should be community engagement with gatekeepers, with the community members about the benefits of this vaccination. And not only that, there should be a health assessment of what are their needs, health needs, not only the vaccination, but other needs also. So these are the two important points which we feel there should be a community engagement in this population.
Okay, good point. So actually, it really wasn't community engagement at all, right? Because it was assumed that vaccination would be a high priority item for them.
Correct.
Christina, thoughts?
Yes. Yes.
What are your thoughts?
Yes. Because I talk about preparation. That's why I was saying you just do not go into the community and do what you want to do. There has to be preparation because this is a special type of community. And therefore, we need some kind of dialogue with a community representative or with the community itself to be able to find out what is the appropriate way of doing polio vaccination with a nomadic community. I agree with that.
Okay, all right, good. Other thoughts from other people? Did someone raise a hand? No. Other thoughts about the Enos?
Yeah, I have a thought. Yeah, in this type of study, it seems that there is no respect for the community.
Oh, okay. Say more about that.
Yeah, because of yeah, in this type of this type of study, there is no they didn't do the community engagement prior before the implementation as well. They just doing the community meeting only after the first vaccination event. So I think this kind they didn't bring in, they didn't participate the community leaders and the community as well. So I think it is just they according to this study proposal, they seem to be like authoritarian, rather than community engagement. So I think they in here that the main essence lacking is respect for the community.
Right. Okay. Good point. Good point.
So also, you see, this is not mainstream. It is not mainstream community. No, this is the community at the periphery, and therefore, community engagement really becomes important before the vaccination is done.
Right. Yeah, and especially with vaccination, right? People have so many different ideas about vaccination, and so I mean, we may think vaccination is important, but other communities may not. So you gotta get the buy-in. Yes.
We have discussed as a group that they should have discussed as a part of the community engagement the barriers for the implementation. They should have discussed if there is a culture context regarding refusal of vaccination, or if it was just the deficiency of facilities.
Or it's just what?
Deficiency of facilities. Just the deficiency of facilities, or there is a culture context against the vaccination as a whole.
Right. Yes.
Studying the depths, the perspectives of the community itself first.
Okay. All right. Good. Right. Okay. Very good. What are your thoughts about data collection?
If I can come in,
Yes.
Manjulika. Yeah, so this is another point that our group also looked at, which is the need for community engagement to understand what would be the best strategies for data collection, rather than just decide on this GPS method of tracking and identifying people. The community might have their own local methods of identifying people and involving them rather than have this top down method of the GPS and tracking.
Yes, very
Right.
good.
Yes. And what would be the concerns with the GPS?
Also, Prof, if I can add something as well.
Yes.
I think due to the lack of engagement as well, it causes the risk of privacy confidentiality among the community as a whole. And I think because given that the fact that this community can be regarded as a vulnerable population, I think there's a need to get consent from a collective consent rather than just getting a few representatives of the community to be part of the tracking study. I think the researchers need to inform everyone in the community about the tracking study.
Right. Okay. But good. What would be the concerns? Let's say they accept it. So what would be the concerns about using the GPS?
Yeah, they can get into problem if there are legal issues. For example, all the heads of the community are being selected. So if they are involved in killing the wild animals, the forestry officials can take action on them, or they can unnecessarily create problems with them. So I think instead of GPS, as Manjulika said, they should think about other innovative methods of tracking them. But very important again is to delink the information from the name or personal appearance of the person. I think being vulnerable group, this group, GPS is not a right method of tracking them or looking at their benefit. No, I don't think it's going to benefit them in any way. For the researcher, it may be benefiting.
Our group,
for them, it may not benefit for the patients.
Our group was talking about informed consent, no? That you have to tell them that if you participate in this study, we will track you, but there's also the promise that we will not share the information with other agencies. It's only for the purpose of this research. So the group was talking about that measure, in the informed consent, so that if GPS may be done, so that's how to address it. And the ethics committee has to look at the consent form, whether it has the proper provisions to guarantee privacy and confidentiality. So it becomes also part of the ethics committee to have oversight over the informed consent forms that they approve.
Henry,
one more thing, I think, Prof, is when the problem, may hear, when it comes to the informed consent, it's like, do they really understand what are the implications of being tracked? Will this informed consent will be communicated to them? And how long will they be tracked? So like, who are these people that will be tracked? How long will it be?
So very important points in the consent form, if ever that's going to be done.
If I may comment, in our group, we have also discussed this, like this kind of GPS tracking, is it really necessary to collect this kind of data, because of it have more risks rather than benefit to the researcher as well as to the community as well, because of, as it is just the first implementation in their community for this kinds of vaccination program. And yeah, so our discussion is that, is this really necessary to collect the TBS? Like if, we have been discussed, like even if it is necessary, then how they will continue with the GDPR, the General Data Protection Regulation, is this aligned with it, and then and then later to include it into the informed consent as well.
Well,
but that should be part of the community engagement. It is not the ethics committee that will decide whether it is appropriate or not, but what is the result of your previous dialogue? Is it acceptable to them? So that's very important, more than saying that should not be allowed. Many ethics committees are very patriarchal. They impose their values on the communities. That's not quite proper. So what I'm saying is that during the planning stage, these things must have been discussed with the community, and to decide whether they think it's appropriate or not appropriate.
Yeah, exactly.
And also, our group had discussed the researchers are collecting many more information than the vaccination. And we need the data safety monitoring system and approved by the ethics committee. And at the same time, we are also discussed about the any other tracking system, apart from the GPS phone system. What if we use just a phone? Now the GPS is on, 24-hour real time. Can they track? They can track people.
They're nomadic.
And at the same time, my question is, if even with the government program to vaccinate a child, can a parent refuse to have their children vaccinated, especially in your country?
We were discussing the laws. No? We were discussing I'd just like to answer that. We were discussing what are the laws related to polio vaccination. And I think that in most countries, polio vaccination is mandatory. No? And therefore, it has to be done. But the issue is how to do it in an appropriate manner with a nomadic community. I think that is that's the moral issue. How to do it properly with this community. And therefore, you should have that kind of dialogue to find out how a mandatory polio vaccination program can be implemented in a nomadic community. I think we should not forget that context.
Absolutely. Now, the GPS aspect seems to me was like a sub-study. They wanted to investigate the feasibility of using the GPS in the future to track nomadic people and be able to deliver services for a future study. The GPS wasn't part of the vaccination. So, they're locating the nomadic people and be able to deliver services is a problem. So this was a feasibility study. Now, for sure, there should be community engagement and make sure they're all fine with that. But what are the concerns with what else would you try to do to try to locate nomadic people? I mean, they're testing out an implementation strategy, how to locate nomadic people. Let's say they have, a certain amount of supplies for food or clothing, and now they have to find out where they are. So that's trying to understand the feasibility of using the GPS.
And would they not have mobile phones?
What's that?
Sorry, I might have missed this, but is there a reason they don't have mobile phones or any other way to contact them?
Well, it says here the GPS tracking mobile phones.
So I mean, you could have a mobile phone, not track them by GPS, but give them a call like you would with any other participant in a research study. There's no real if you're going to give them a phone to track them GPS, you can actually give them a phone and say, I'm going to call you in 1 month to follow up. I'm going to call you if I need to give you some supplies. Like, there's really no reason to track people.
Well, you raise a good point, but that is I mean, I just don't know if that's an adequate method.
We don't know about nomadic communities. That's
exactly, and that's why we need to go to the community and say, look,
yes,
we have if we have supplies, if we want to get something to you, how would we get them to you? If they're like, look, we don't want your supplies, don't contact us. We have to be like, maybe we don't do research in this community.
Well, I think one needs to. I mean, I certainly don't know enough of the different methods of locating nomadic people. I'm not a specialist, so I would not necessarily be critical of the GPS. Let's take an open view here. Maybe for whatever reason, using the phone is not the best method. I'm just trying to be open here.
I think the key point is to be open.
Right. That's the word, open.
I
think ethics
transparent and open.
Ethics committee should be open-minded as well,
I don't know. I don't know about that. I think ethics committee should be very strict. And I think that
that's the problem. No, that's the problem. I think ethics committee should be open-minded as well to find out what's on the ground, rather than say, no, you cannot do this. No, you cannot do that. You have to
can I just make one point on that? Can I just make one point on that? As ethics committees were being built and created, there was a community member as one part of the ethics committee, right? We all know this. On every ethics committee, we have a community member. Right. And the reason we had that was so that we can keep in touch with on the ground realities and practicalities and risks. Right. But as we work with vulnerable communities and marginalized populations, we might be doing a project on an HIV population, but the community member sitting there is not part of that community always.
Right.
It's actually just a general community member who doesn't have any insight into that community. So what I would suggest, and what I think will be the next stage of working with vulnerable populations, would be to invite someone from that community.
Yes.
And how to choose that person and how to make sure that's ethical is a whole different thing. But so we still have that major idea of having a community person on our ethics review committee, but make sure that community person represents the people we're studying or we're working with.
Right. So you may invite, not necessarily as a member of the ethics committee, but you may invite a resource person, who would be familiar. In the Philippines, for example, they would hire some anthropologists who has worked in that community, to explain how they do things and all that kind of a resource person. I think it's very important to understand the community.
If an IRB serves 10 communities, that may not be very efficient. In the U.S., the major role of the community member is to look at the informed consent.
Yes, yes, we do that.
And that's it, though.
But the informed consent covers everything. It should cover everything that's happening in the study, how it's going to be done, what's going to be done with the data. It does cover a majority.
No, the values of the community, just by reading the informed consent. Anyway.
But I challenge what you said. I don't see why. Sorry, I don't see why it matters if it takes a long time, unless it's an emergent study. I think that's the problem, is that we shouldn't be worried about it taking a lot of time. We should be worried about it being ethical. And if it's something
if I may add, sometimes we interview the researcher and we ask them, have you been to this community? What do they say, And if she has not been there, then we say we require that kind of information, So that's how you manage it, So it's not really another person. The researcher herself should be able to do that even before she is granted approval for a study.
Right. Well, I think context is important, and there may be different models depending on the area that the IRB serves, and blah blah blah. But the major point is that about the community engagement, for sure. No doubt about that. So, all right. Any final issues? If you anyone ever want to develop a case that's controversial, throw in the GPS aspect of the case and track people.
Henry,
yes,
I just want to share that maybe any one of you might read the pre-reading Henry posted on the website, the community engagement paper of "Do No Harm is Not Enough." So, like I learned that our researcher as well as ethical review committee, we have to think of the model of participatory research when we do with the community in any kinds of project or research. In this case, also like Christina mentioned, the project manager or researchers have to plan well, prepare well, and we have to get that community participatory, and that will be everything good. It's a main point, I think.
Right.
Right. Yeah.
So you ask for that data. Ask for that data.
Right. Yeah. Absolutely. Thanks for those remarks. Right. Do no harm is not enough. Even in the doctor-patient relationship as well, do no harm is not enough, for sure. Thank you. Okay, very good. So I think this has been a very good day regarding community engagement, implementation research, equities, and I'm just, on a personal level, I like to know more about, know more about engaging communities, but also getting my feet wet about the actual process of engaging communities. I think that's something that, coming from the US, even though we're trying to do that more and more, it's not it's not really on the radar screen. Yes.
Henry, there's one more point which I just wanted to bring to your attention. I think ancillary care also is very important here. I think some of my members in my team pointed out that very importantly. For example, there could be malnutrition in these children or low birth weight. So I think the talk which Christina had given about ancillary care becomes very important and vital in this population also. I think we need to think about that also.
I agree, but I would add that one needs to think about the scope of ancillary care, because that could be quite expensive.
Right.
And there's been many good papers written about what would be the scope of ancillary care, and what's the justification for ancillary care, because it's not related to the study, and there's been a lot of good thoughts about why ancillary care. I mean, there's a lot of reasons, but I think that's a very what I'm trying to say, a very important topic, but it needs to be unpacked in the right way, because like everything else, it's a balancing issue about resources and obligations. Okay, well, thanks for bringing that up. All right, so
can I just ask a question?
Yes.
Here? This is regarding the point about this being optional, this vaccination, or it being mandatory because it's a legal requirement. So where does community engagement come in to make the program successful? So how do we bring in that, the need of the larger system to ensure vaccination? I think this is an interesting point even now when we look at COVID and COVID vaccination. Is it going to be optional? Is it going to be, so where does research come in, and where does the program come in, the policy of the government?
Is there any area in which vaccination is mandatory?
Polio vaccination is mandatory.
Where?
MMR in the Philippines is mandatory.
Mandatory?
Yes.
Yes.
Okay. Interesting.
Yeah.
And no one could.
In many Asian countries, some basic vaccination are mandatory.
Oh, okay. Well, all right, but
not all vaccination are mandatory.
All right. Okay.
MMR is mandatory.
But should the COVID vaccine
not
be?
COVID.
Right.
Not yet. No.
Not yet? Okay.
I don't know. It's not mandatory.
All right.
If I may add, so if it is the vaccine is mandatory, so what's the punishment for those who didn't take the vaccination?
What's the what?
Actually, they look for you. They look for you, you know. They ask the local health system, who are the people, you know, who did not have vaccination. I think in Myanmar, it's polio vaccinations also mandatory. Am I correct?
Rather mandatory, but not all people are having the vaccinated.
Right. But that's a weakness of the health system, you know. If the coverage is not good enough, then it's considered as a weakness of the health system. That's how it's looked at, public health,
Sure,
right?
we don't have a full coverage yet, but I would just like to know that, you know, what would be the implication if the one who refuse to take the vaccination. Yeah, that's all.
That's a good question. So we'll see what happens with that. Okay.
Most of our countries do not do anything. Most of our countries do not do anything if you refuse to be vaccinated, but they worry about epidemic breakouts, you know.
Right.
So they try to track who was not vaccinated, right?
With the
And they
GPS,
visit
right?
your home. Right.
With the GPS. No?
I don't know.
All right, very good. All right, so we have a optional session coming up about an REC network. So all those interested in talking about an regional REC network, why don't you stay on and join us in about 15 minutes? How's that?
That's great.
Okay.
That's great.
And one last thing, I would like to also add some important point in our context regarding the GPS tracking. As we know, just sharing the context here. Like the implication of GPS tracking is, you know, like is significant. It depends on the context. Like in Myanmar, as you know, the longest ongoing conflict and you know, diversity having these types of situation by using the, you know, GPS tracking, and its implication would have been involved the political factor and might be, you know, might be endanger the safety and security of the research participants. That's right.
Well, that's a good question. Now, having said that, what do you think about GPS tracking or tracing for COVID? To find out where COVID is, who has COVID.
I know that in Japan, you have to give consent for them to track you, you know? So consent is still there, but I don't know in other countries.
In the US, it's done in an anonymous way, and there is an app to find out where the density is, and I tried to download the app on the phone, and guess what? I have to upgrade my phone in order to download the app. So, I mean, if it's if there's no privacy issues, you need consent. And here we have the individual versus the common good.
Right. Right.
And
Right.
if there's other ways to trace where COVID is and avoid a lockdown, which has a lot of adverse consequences for groups who cannot socially distance, the app might be a very good idea in that context. So I think I'm glad Calvin talked about the digital technologies. I think when used in the right way, it could have a lot of benefits. Used in the right way. Okay, very good. So let's reconvene in 15 minutes. Okay? All right. Very good. See you soon. Okay, is everyone back? How we doing here? If you're back, show your face. Don't be shy. Ah, here we come. There we go. Ah, okay. Very good. So, thank you all for coming back. Gee, we have 90% came back. You that's excellent. Very good. So there's I enjoy reading all your comments on SurveyMonkey, and I will download the whole document and send it to everyone. Okay, and that goes with the equity survey as well. So let's. I like to get done in 45 minutes. Okay, so let's get started, and we have a to get us started. We have Dr. Kintet Way, who will give a short presentation about a network. So, Dr. Kintet Way, are you going to share your screen, or you want me to share mine?
Please share, Prof. Henry.
Okay, all right, no problem. Let me do that. And we're already at the steps. Okay. Oh, wait, now, hold on. Let me stop that. I don't like what I just did. Right, how's that? What is that again? Hang on. All right. Do you see the PowerPoint?
Yes, I can see.
Okay. Very good.
Yes, Henry.
Okay. I'm getting good at this. I'm going to quit my day job. I think I already did that. Okay. All right. Doctor, why don't you, we have, why don't you say, introduce yourself. How's that?
Yes, okay. I'll start.
Okay.
I'm Dr. Kinta Wei from Myanmar, and currently I'm serving as the chairperson of Institutional Review Board from Department of Medical Research, Myanmar, and my background is public health. So before this presentation, Professor Henry Silverman has discussed with me about this important issue on networking research ethics committees in the Asia and the Pacific region that will promote or enhance more quality ethics reviews and sharing knowledge within the region. Then the first question is, why is regional networking of RECs essential? This is a very important question. Day to day, every RECs and IRBs are conducting ethical reviews of research proposals, and we have three reasons. The first reason is to uphold the scientific integrity of research proposals. This is very important, and especially to prevent scientific misconduct. And then second one is to ensure the highest degree of protection of human research participants, for which each and every IRB or RECs should give special attention. And then thirdly, to monitor whether the research is carried out in an ethically acceptable manner. In the first place, you can find some protocol deviations, and ethical oversight is extremely important. And the aim of this presentation is to keep three outcomes of an independent review process in place. When we conduct an independent review process of research proposals and approval of research proposals, we hope there will be a high credibility for public acceptance, and then creating trust and confidence. Next slide, please. As such, to meet this particular aim, we have challenges for quality reviews. For each REC or IRBs, we need to collaborate each other. There are two major concerns that call for collaboration. The first concern is that, as you all know, there is a rapid advancement in technology, incorporating in many research proposals submitted to our IRBs. That is involvement of digital technologies, using applications, uploading data to clouds, artificial intelligence, big data, so on and so forth. The emergence of new disease conditions, research methodological designs, for instance, implementation research that Professor Christina Torres have already pointed out, the ethical considerations, what is differed from conventional ones, or the traditional or other types of research designs, that is clinical research, biomedical research, so on, and adaptive designs, and public health emergencies that require global and regional guidelines, and we cannot use the conventional ones. Next slide, please. Another question is, we need to know the current situation of networking RECs at the regional level. Is it existing? Yes, may I say that it is yes, but not fully yes, because there is as FERCAP coordinator, Professor Christina Torres is present here, FERCAP, that is Forum for Ethics Review Committees in Asia and Western Pacific, exists as an exemplary of the promising space to form a network between its member RECs or IRBs in the region. Actually, this is not the network yet, but this is a promising space that I would say. And then we have coordinators, including me in Myanmar, and then FERCAP coordinators in each of the member countries could assist the independent evaluation for accreditation of RECs or IRBs in the region. By and large, the annual FERCAP conferences are highly educative in a friendly atmosphere. That is not only me, but maybe everyone who have attended the conference regularly may feel like this. It is really an eye-opener for understanding cultural differences, which is especially obvious in multi-country when presenting multi-country research projects. You can see the cultural differences, and ethical considerations are depending upon that social values and contextual systems. And then there are ways of exercising local regulations and laws, etc., which should be an important requirement once the network is formed. Next slide, please. And then we need to know what would be the benefits by networking RECs in the region. Are there any benefit or no benefit? That is like the processing the ethics review of research proposals. We are always weighing the risks and benefits. So we should know what would be the benefits. The first obvious benefit that I could see is through networking, we can enhance the continuity of capacity building process of IRBs or RECs through sharing expertise in bioethics by provision of consultancy services. And then next point is creation of an opportunity. This will be the great opportunity to seek common ground for the upsearch of ethical questions or potential solutions for ethical dilemmas related to innovative technologies and new research methodologies. And then it is likely to support coherent reviews and harmonization between each and every IRB in the region. Fourthly, we can gain an insight into laws, standard operating procedures, and variations in organization setup, infrastructure, and practice in RIAM. Next thing is we can gather information through the active network about local RECs to foster the establishment of a knowledge base so that we are always updating, and then we can catch up with each and every REC's situations, what they are attempting to innovations or what they are attempting to adjust with the local conditions. We can know each other. And development and sharing of training materials and other resources is also important. And then enhancement can enhance through the network for conducting multi-country research with IRBs. For instance, in the FERCAP region, FERCAP, Professor Cristina Torres has already coordinated the multi-country research on COVID-19 ethics. Next slide, please. Here is a diagram that Professor Silverman is creating the survey monkey, and then the respondents give their opinion.
So this is the results of what you guys said. This is your slide. You want to, Dr. Get that way, just
could you make it full screen, please?
Why is that not?
Slideshow. Click slideshow.
Yeah, no, that's what I'm doing. Hang on. That's a little bit better. I don't know. So
No, it's slideshow. It's not on slideshow. It's normal view.
I know, but it's not clicking. It's I don't know why. Hang on. Let me. I'm just a tech boy. Don't yell at me.
Sorry.
Stop yelling at me. What do you see now?
Yeah, it's in slideshow now.
Oh, okay,
Now it's clear, Henry.
Okay, very good. Okay, so we have several. This is enhance harmonization, provide regular workshop training, conduct research, network meetings, serve as a resource, a listserv, not too popular. So comments on this slide. If I could invite comments from the audience.
They look good.
Well, let's be a little more granular.
I have a question. How does harmonization work when we have different regulatory bodies in our own countries?
Well, that's a good question. So we have to unpack the word harmonization. Harmonization of what, right? So it could be SOPs. There's no regulations on the content of the SOPs. There may be regulations on member size and distribution, but I think that we have to discuss. Well, it's very interesting. Harmonization is a very vague word, but yet a lot of people opted for it, and which could be due to the fact that different people have different concepts of what harmonization is. And I think we need to further explore what should be harmonized between the different IRBs to ensure that there's consistency among IRBs in how they review protocols. It could be a certain process, a certain checklist, like what do you review in a protocol that's collecting biospecimens via broad consent? What are the additional elements of an informed consent for collecting biospecimens for future unspecified research? So I'm just throwing out an idea, but thanks for bringing it up. So now, I mean,
Sir, how about consultation services? Is that included in the serving as a resource for RECs, consultation services?
Good question. It could be serve as a resource for RECs. The whole concept of consultation services is a very interesting concept. And at my institution, we have a separate group providing consultation services for investigators, external to the IRB. External to the IRB. That's something to have more discussion. And now it may be problematic in the sense that that person or that group needs to know about the different regulations, but it's something that should be on the table. Other thoughts. I think the now FERCAP provides regular workshop training, network meetings, does some research. Other things that a network could provide. I do a lot of work in Egypt, and we established a network 12 years ago, and the network has regular meetings 4 times a year, like one-day workshops. Now, that's different from a regional meeting, but actually, COVID is teaching us something about the virtues of virtual meetings.
Right.
Right?
Right.
And let me just say that, think about this. We've been meeting for 2 days here, and if it wasn't the virtual setup, I mean, look at all the people here we're connecting with. So maybe there should be, webinars every 2 months. There's this organization in the US called PRIMA, Public Responsibility for Research and Medicine, and essentially it serves as a not so much as a network, but it provides regular webinars and resources, and they're having a virtual meeting in the next few weeks, and the deadline is November 30th. And let me send you the link, and people could see what they offer on their website, and maybe we could replicate that if that's something to do. Christina, you know about PRIMA, right?
Yes, yes. Yeah, I think we can go on doing this kind of workshop. I think the 2-day workshop was very successful. So you can say we can have semestral workshop, quarterly workshop. I think we keep what we have been successful in doing to maintain the network. Consultation services very difficult in the sense that we are coming from different countries.
Right.
There's no one answer, there's no one answer to all the questions, and it requires some kind of expertise. So that's kind of difficult to have. But doing a workshop like this, it can focus on some IRB procedures. It can focus on some important topics. The topics in the last 2 days were very good. And I think it was very informative. And it gave a lot of insights to many of us. So I think something like this will be more workable. So that's the second one, which I think is the highest, provide regular workshop training on what is the current hot topic, like adaptive design, human challenge research, so that it keeps everyone updated about the state of the art related to methods and how ethics committees can review them. Harmonization also, like we can share assessment forms, we can share how to monitor. So special topics like that, I think, will be very useful to this group, considering that I think we have generated enough interest in what Henry has chosen as topics, important topics for the last 2 days. So I would think of it in that way, which I think is more feasible, rather than consultation. Consultation is very difficult. Sometimes people email me and I have no idea how to answer the question, so and I always say my reply would always be, it depends. It depends on many things. So that's kind of difficult.
So
but
I think that needs to be more engagement,
right,
among the members of a network,
right.
And I think using the virtual platform will, especially for a region, would be able to accomplish that.
Right.
Engagement. Because right now they have that one meeting every year, but you need more than that to have adequate engagement. So let me, Dr. Kintedway, where'd you go?
We can share good practices of IRBs, if you're interested in that, then we can share, what are the issues about research design, public health research, economic studies, environment research. So I think this will be very interesting for the members of the network.
But where's, I want Dr. Kintedway to finish her presentation. Where did she go?
Sir, I have a question.
Yeah.
Yeah. I for example, there are certain problems that are common to our area in this part of the world. Like if somebody wants to do a research that will involve countries where we are concerned, is there a role of this network to do a central review site, something like that, that all of the experts from all the countries will contribute and try to come up with a review or a core protocol that can be applied to the different countries? I think it's good that we're sharing experiences and then lectures, etc. But you don't have to be a network to share your experiences or listen to lectures like this. What I was thinking about is a network of countries, particularly with objectives of improving research as well as ethical reviews of topics concerning our particular countries. Is that correct? If I may ask, of my view, what is a network supposed to be?
Well, that's what having this meeting to see if to bring out what would be the benefits.
That's right, sir. I was just think I don't know if it's possible or feasible, but perhaps we can also explore that area.
If I may give some answers to your question, Rod, no? You see, Asia is a very diverse region, all right? You have to take that into consideration. We are very diverse. What is feasible in one country is not feasible in another country. So in terms of network, we can highlight that diversity. But for us to say that there is one kind of protocol that, that's kind of difficult, and one kind of ethics review, that's kind of difficult. In FERCAP, we always look at local laws and international guidelines, and we make adjustments on how they comply with local laws and international guidelines. So it's not one size fits all. So you have to take that into consideration.
I understand that, ma'am. But my point is, if we have a common problem within our countries, and then we want to discuss it. We want to discuss if we're going to do some research or something like that. Ain't it a good objective of the network to share our thoughts, the individual thoughts of the region or the countries, to come up with a good research also, something like that?
If they're interested in that, you should look at your local network.
What have we been doing
with the
past 2 days?
Yes. But application varies,
different countries and discussing the same issue.
Right.
So
and thinking of application to each country. No one.
I mean, there's an overriding commonality of a certain type of research. And then when you drill down to your particular context, it'll be different. In my country, we have 50 states, and we're all very different. And we have local laws as well. And we have an overriding general, you could call it national concepts, but it's broad. And so one could say we have a network of 50 different states, and we're all very different. And so I think that model could be very applicable to this region as well. I think the issue is, well, I don't know where Dr. Kinfadway went to, well, here, I mean, she has collaborate, and I think we need to unpack that word, collaborate. Collaborate on what? Well, I think collaborate on research projects. Several years ago, I had developed with my colleagues this self-assessment tool for IRBs, and we did a study looking at IRBs in Egypt, South Africa, and India, just to see, and the self-assessment tool was based on international standards, and we wanted to see what differences, if any, between the different regions, and also increase the sample size as well. And so we could, now this meeting for 45 minutes is not going to unpack everything here. The question is there enough of something that we could all benefit from to the point where we could further discuss whether there's any virtues in having a network to collaborate on stuff, whatever that stuff is, and coordinate between each other, well, and hopefully cooperate as well. And what was I going to say? But I think what I said before, we haven't, in the region, haven't met more frequently enough to see what, I mean, we're all doing the same thing, and, you know, if we met more frequently, maybe we would, you know, that would lead to other benefits. I mean, the other thing I wanted to say is that in these last 2 days, with all the interaction, I just feel like I now know a lot of people. And I'm just wondering if we do that often enough, maybe that would lead to building blocks. I don't know. I'm just, brainstorming.
Right.
Other thoughts?
Henry, I have a suggestion and Henry.
Yes.
So what I was thinking also is there are a lot of people are there who really are interested in research ethics and especially willing to be part of community research ethics committees. But I feel the kind of training is very, very minimal. There is actually, we all learn through experience, but that should not occur in the future. I feel like we have a good clinical practice. We should have some kind of a course where essentials of research ethics committees are taught. Like, no, that can be a kind of an universal course, which like amateurs can learn, and definitely they can build it on from that. I don't think there is any course like that which will certify you saying that you have that minimal qualification of you're ready for a research ethics committee. No, I think creating one would benefit a lot of people who are interested in this area, and it will also give lot of we should also give a lot of weightage to that. No, like when you're forming committees or when you're forming independent ethics bodies, also it will be of very valuable aspect, because it's very essential that amateurs are trained and a minimal standard is kept so that they are certified.
Now let me show you this website, just so that you know what I'm talking about. So you all see the PRIMA website here. Is that on your screen?
Yeah. Yes, Henry.
Okay, so let's see. So they're having a meeting here, and where's the oh, yeah. So 2020 virtual conference. Now they have it over 3 weeks, 2 days per week. And let's get, and they have a lot of content, a lot of small groups, but let's let me see, how much does it cost, right? So yeah, it's not cheap. Non-member $450. Oh wait, 1 week only. Yeah. So that's the problem. It's not cheap. Let me, I'll tell you what, let me call them up and see if I could get a reduced rate, okay, for you guys. But anyway, so this organization is like the network for the US, and let me just go back home. So they have short courses, online learning, and research ethics and COVID. So, and webinars. So they have a lot of online stuff. And I don't know if that's something for this group, but I think
Henry, what I was trying to say was whether as a group, like the formation of this group, REC, can develop some kind of a curriculum for amateurs or who are interested in the beginners, like whether we can develop some kind of a curriculum and help people to get a minimum qualification to go into IEC, so that they have some kind of a baseline qualification to join any IEC. That's what I was trying to say.
Right, yeah, but I agree with that, but you have to also think about who's going to do that.
Right.
Okay.
No, I mean, people would be definitely interested. I mean, learned people would be definitely interested in that.
Who would roll up their sleeves and do that?
We can do that.
I think that's what I'm saying. Can't the REC
Well,
do this?
Dr. Johnson, I have a suggestion. We can set the curriculum. Sorry. We can set the curriculum and the local ethics committee can certify. So, you know, if you have a curriculum and the syllabus in place, whichever the candidate's local ethics committee is, can facilitate the certification.
I think
rather
that would
than
be really a great work. Like.
Well, that definitely warrants discussion. And I think all this conversation could serve as a foundation for further conversations.
Sure.
May I add something, Henry?
Yeah.
I think we can do that. If we can work together per CAP, we can develop a curriculum. What I want is an Asian curriculum, you know, rather than a US based curriculum, because we have similar settings, concerns, right? So maybe per CAP can do that with you, in setting up basic ethics training for members of research ethics committees. And then I also would like to announce that we have an online conference on December 7 to 9. But it also has cost. It's $100. But I sent a call for abstracts. But right now we have finalized some kind of training. So I think it's more of a regional network that we would like to have, rather than attending a US program, which may not be relevant to us, because the types of researches are different, more of public health. That's what I see in the Asia Pacific region. The concerns are different, the laws are different.
No. Hold on. I mean,
I'm proposing an Asian network.
I'm proposing a network among people in the Asian area. Not necessarily an Asian network. I think, again, look at COVID.
Right.
That has universal implications. We're all essentially addressing the similar problems. my colleagues in my hospital are constantly calling up the doctors in Italy. And I think that there's a lot of commonalities between the different regions in the world, and the now I'm not saying join Prima. I was bringing that up as an example of what a network could be in providing resources, common meetings that could bring us together, make us know each other better.
Right.
With more common interactions. Because right now, as an outsider, I don't see that happening. And I think also we all have different ideas, and if we come together more often, okay, we're going to be able to share those ideas and know what other people are doing. I don't think we know what other people are doing, thinking about. I think that we need more brainstorming sessions around common cases and come up and, just move forward. Right now, just having this conversation is, I think, is putting a lot of stuff on the table. I just think, and I apologize for, I feel a little uncomfortable in the sense that, who the heck am I? I'm not from this region, but maybe one day you'll make me an honorary Asian. But
we will.
Okay, very good. But I'm just thinking that I think we don't know the benefits of coming together on a more frequent basis until we do it.
We have done it. We have done it.
Where? On a more frequent basis.
Hello, Prof. Henry, Prof. Christina, and online colleagues. I have some information to share. Dr. Kim Tae-Wee phone, while using, was dead and unable to connect and talk. I'm sorry to bust the information.
What's that? What happened?
Dr. Kim Tae-Wee's phone, while using, was dead and his internet connection was interrupted, and she was unable to continue her presentation.
Oh, well, she was using a personal hotspot?
Yes. That's why she contacted me and to pass this information to all of you right now.
Okay.
And originally, the idea of networking REC is the idea of the Department of Medical Research, Myanmar, and then it is now becomes the idea of our Ministry of Health. And originally, we intended to to be networking with the local REC in Myanmar first, and then we try to collaborate with many other countries, and we are doing some 3C, such as the collaboration, coordination, and cooperation. Thank you.
All right, well, thank you. That's very helpful. So I think that I think there's a lot of food for thought to see if one could keep up the momentum. I think the what you just said also makes sense in the sense that let's see what kind of network could be formed in Myanmar